Good afternoon. Welcome to the Pan-London Regional Teaching on Lung Cancer. It's our first post-COVID event. My name is Saira Khalik and I'm the North London Medical Oncology Specialty Training Rep. Apologies that I'm not able to be with you today. However, I'm absolutely delighted with the fantastic lineup that we have this afternoon. I would like to thank each of our speakers for giving us their time. I'm also grateful to Dan, the other reps, and the Association of Cancer Physicians for allowing us to use their Zoom software. In addition, due to the virtual nature of this event, we've been able to extend it to trainees and fellows both in and outside of London. So welcome and thanks for joining us today. At this point, I'll hand over to Dan.
So thanks for joining us for today's teaching event. As you can see, the programme is on the screen in front of you. We have 4 eminent speakers today presenting on lung cancer, and we're pleased to have over 75 of you registered. I think the participant number will increase as time increases. We're going to start off with James Spicer talking about the overview of SACT for metastatic lung cancer, before moving on to Sanjay Popat, who will give us an introduction or an overview of the role of genomics and targeted therapies, before a short break of around 10 minutes, before moving on to talks from Dr. Tom Newsom-Davis on the overview of SACT in neo and adjuvant settings for lung cancer, and ending on Dr. Martin Forster's talk with what's new in early phase studies in lung cancer. So a really great programme ahead of us, and we look forward to hearing all of the talks today. Before we start, I just wanted to remind you of a couple of other webinars that you'll have access to. So first of all, the ACP runs regular monthly webinars on the 3rd Tuesday of each month, which all members and non-members are invited to join. You can sign up to these by looking at the acp.org.uk. We have our next session on renal next week with Professor Thomas Powles and Benji Venugopal from Beatson in Glasgow speaking. Another thing to point out is the BTOG website, so btog.org. All trainee members can register as a member for free. I think it's a really good society to be part of. So if you're interested in lung cancer, it's a really good opportunity to get involved in more things to do with thoracic oncology, such as participating in their annual conference. But as you know, BTOG also does regular webinars as well, which are really fantastic. So I'd really encourage all of you to sign up and register for that. Without further ado, I'm going to hand over to Kara Stavraka from Guy's and St. Thomas's, who is your trainee rep at Guy's, who will introduce our first speaker of today.
Thank you very much, Dan, and thank you very much all for attending this training session. We have the pleasure of having Professor James Spicer as our first speaker, talking on the overview of SACT for metastatic lung cancer. Prof Spicer is a consultant medical oncologist at Guy's Hospital and a professor of experimental cancer medicine. He has established our phase 1 unit at Guy's Hospital and directs King's ECMC. Thank you very much, Prof Spicer, for having the time for our lecture today. We will ask questions in the end. If you can type the questions on the chat, we can address them in the end of the talk. Thank you very much.
Well, thanks, Kara, for that introduction and for the invitation from your organization to speak to you today. And it's absolutely my pleasure to speak to oncology trainees. I suppose I wondered whether it was going to be my pleasure when I was given my title. So talking about all of lung cancer in whatever we've got, 45 minutes less, if we're going to leave some time for some chat and discussion, is impossible. But I'll give it a go, and I hope you can see my slides. This is what I'm going to attempt to cover. Like I say, after reviewing with Kara and Dan, it was clear that actually I should try and cover even more than lung cancer, because we ought to include other thoracic malignancies where big things are going on, and that's for sure the case in mesothelioma. And I'm going to try and cover very briefly small cell, where there has been some development in recent years after many decades of very little progress. So we have a very broad landscape to try and sketch in some detail. Obviously, as I've said, we can't do everything. So my philosophy for you this afternoon is to give you, without making too many prior assumptions, what you might need to survive in a lung clinic if you're just starting your first rotation in the thoracic service. So we're going to have some pretty straightforward, basic, and in some cases quite old data, which still informs what we're doing now. I'm also going to, to keep all of you interested, even those of you who've maybe done quite a lot of lung cancer and other thoracic malignancies. I'll try and flavor and leaven the mixture with some updates, some of which are extremely recent, up to and including ASCO from this last weekend. So a little bit of background on lung cancer, as if you need it. I think what's key, whatever disease you're looking after, is having an idea of scale. And that's why I quite like this slide with some UK numbers. Lung cancer, of course, is a very common malignancy and still the biggest single cause of cancer mortality. And when you look at the basic numbers like this from Cancer Research UK, with a bit over 45,000 annual cases, that's a number to keep in mind nationally, and in excess of 35,000 deaths, you don't have to be a mathematician to see that the outcome for many of our patients is still pretty terrible. So this is where many patients hear when they're diagnosed that their outcome may involve overall survival of around or less than a year for some patients. So and that's unfortunately taking all comers, that is a gloomy prognosis, but as I say, for the average patient, including patients presenting elderly and frail, it's not unrealistic for some. Having said that, as we'll be emphasizing in the next 30 minutes, spectacular and serial developments in really quite recent years are beginning to move the dial quite significantly. So, still we're talking about long-term survival in a minority, with the advent of, amongst other things, screening and at the other end of the staging spectrum, immunotherapy. We're beginning to see some change there. And it's important to recall that there's still a lot of smoking discussion to be had around lung cancer, and we'll come to that in a moment. But essentially, although this is a preventable disease in the majority, it's important to note that actually the proportion of lung cancers unrelated to smoking exposure is rising significantly in absolute numbers and very significantly proportionately. And of course, these patients are usually younger, quite often female, and even in Western cancer centers of East Asian ethnicity. But sticking with smoking for a moment, I think as a cancer physician, it's important to have some feel for these sorts of statistics. So we've known since Richard Dole's original epidemiological analysis that the relationship between cigarette smoking and cancer is a close one and is dose related, as the panel on the left here shows, which is a classical epidemiological smoking gun for a relationship of exposure and cancer. And of perhaps more direct use after the horse is bolted for you in the clinic is the panel on the right, which is telling us that even if you're meeting a patient who's quite senior in years, it's never too late to be talking about quitting. Seeing a patient in an adjuvant clinic who's still smoking after resection of a lung cancer is a bit of a heart sink, and arming that patient with this sort of information that even if you're able to stop smoking in your 60s, you're able to proportionately keep your relative risk reduction only huge rather than massive. This is a snapshot of the epidemic of smoking and lung cancer in developed nations. This is the example of the United Kingdom with CRUK data again. And I think this is really instructive and helps us understand what's happening in the clinic and what's happening to our patient numbers. So you can see it's rather, in a cliched way, blue for boys and pink for girls, this figure, and the solid line is the best estimates of smoking prevalence in any given year, and then the incidence in more recent decades in the broken lines. So you can see, as you probably were already aware, that the prevalence of smoking sort of peaked during the Second World War and has been in steady decline for men ever since, right up to the present day. Therefore it's gratifying to see that the incidence of male lung cancer has been in steady decline now since the 1980s, and you know, overall we've seen a halving of what was already a very common disease, but at least going in the right direction. For women, and some people are a bit surprised to see this, the peak of smoking incidence came a lot later, and of course the societal pressures and influences were very different according to gender, and with increasing social acceptance of smoking in women, the peak in the smoking epidemic in females didn't come until the late 1960s. But since then, the decrease has tracked men. But because the peak was so much later, then we've only just passed the peak of incidence of female lung cancer, and you can see the incidence curves have approximated probably around now about equivalent, which is really changing the demographic of the patients that we see every day. So, you know, that's a little bit of developed world history, and the take-home message there is positive. Sadly, the take-home message globally and for the great majority of the world's population is anything but positive. And this slightly complicated graph, which is basically a set of Venn diagrams, shows in a number of developing and nearly developed countries the relationship between total population and smoking prevalence. So you can see, for example, at the top right here, that amongst Chinese men, population of about 500 million people, there are nearly 300 million smokers, and that, of course, is a ticking time bomb for an absolute explosion of smoking-related disease, including lung cancer, and similar numbers occur in other very populous places like Indonesia and the Indian subcontinent. So in those parts of the world, we have a very major global health issue to deal with. Turning to what you might have been expecting me to start with, staging and therapeutic options. I'm not going to spend too much time on this very basic slide, but suffice to say, this is sort of what we thrive on in the lung MDT. Staging is for allocation of patients to a treatment modality, and in general, for those of us dealing with systemic therapy, we're talking about adjuvant treatment in resectable disease. We're talking about concurrent radiotherapy, and we're talking the emphasis for today on the treatment of stage 4 disease and stage 3 disease, where disease is not encompassable in a radiotherapy field. So let's get stuck into some boring but important data on the systemic treatment of non-small cell lung cancer. So when I was at your stage, this kind of trial was what was supposed to get us excited, and such was the slow rate of progress in medical oncology, particularly in thoracic oncology in those days. This was about as exciting as it got. So this is comparing different flavors of chemotherapy, and still informs the treatment that we give today. So this is platinum doublet treatment using either one of the two so-called, laughably now, modern chemotherapy agents, comparing pemetrexed and gemcitabine in platinum combination, and in non-squamous non-small cell lung cancer. And you can see there was really quite a meaningful separation of curves with a hazard ratio approximating 0.8, which is when we start to get clinically interested in statistics. And as I say, for the time, that was about as big as it got. And certainly this brought pemetrexed as into the standard of care for which it remains when we're giving chemotherapy to people with this histology. If I'm giving an overview of the treatment of lung cancer, I need to mention again adjuvant treatment, but I know, I think it's Tom Newsom-Davis is talking about perioperative treatment later on. So this is all I'll say about adjuvant treatment for now. You can see from the citation that this was the same year as the publication of Giorgio Scagliotti's pemetrexed data in advanced disease. So, you know, this is now quite well established in the history of lung cancer treatment, but still informs what we do. And you'll see in this slightly complicated color-coded chart here that there was actually quite a number of randomized trials which still contribute to our understanding of which patient groups we should be offering platinum doublet chemotherapy, generally in combination with vinorelbine. And you can see in the color code here, a green box means that trial didn't include that particular stage in their eligibility. And then it's only the red boxes where there was a positive, statistically and clinically significant effect noted. So you can generally see that for adjuvant chemotherapy, we're not interested unless patients have got either a larger sized tumor and or nodal involvement. I'm also going to skate superficially over personalized medicine, that is molecularly targeted therapies in lung cancer, because Sanjay Popat, speaking next, is going to talk to you about both diagnostics and the targets and the targeted therapies that those inform straight after this talk. Suffice to say, though, you know, this is an area which has exploded in the last 20 years, and now you can see that this pie chart is a bit out of date, but even in 2012, we reached a tipping point where for lung adenocarcinoma, more than half of our patients at diagnosis, if we look carefully enough, have a driver mutation, which at least in 2021, we were able to target. So the last brick in that wall, most recent brick in that wall to fall into place, of course, is targeting KRAS, which I'm sure Sanjay will refer to. But again, sticking with my sort of history theme, I think it's worth reflecting on how these targets were identified in the early days. And this is a great example of what I call reverse translation. So we're very familiar now with the activating mutations which drive some patients with lung cancer, and these mutations are all clustered around the active site as this molecular structure here illustrates. That space-filling molecule in the middle is not ATP, although this is the ATP binding site. That's one of the earlier generation TKIs binding competitively in the active site of the enzyme, and you can see that the activating mutations, which of course wouldn't all occur in the same molecule in the same patient, but if we put them in this aggregated hypothetical structure, we see they all cluster around the business end of the molecule, and it's not surprising that they then are able to increase the affinity of the oncogenic protein in the patient and drive the cancer, but then on the other hand serve as the Achilles heel of our patient's tumor if we're able to come up with a drug which mimics ATP and binds exquisitely with exquisite avidity in the presence of these activating mutations. So that's how these drugs work, but that's not, we didn't know that when these drugs of earlier generation of EGFR TKIs first went into patients, and it was only through the genetic analysis of super responding patients in the trials that these activating mutations were reversed into as a result of the drug development leading the understanding of the biology. I think that's a really important point to note, and has many other there are many other examples of this sort of exemplary derivation of how to use targeted drugs in a molecularly targeted population. And you know, you will still see patients on these earlier generation tyrosine kinases, won't you, in today's clinics? But you know, they're their card is marked and they won't be around forever for reasons we'll discuss in a moment. But there are a whole host of randomized trials, many of which are the bigger ones are summarized on this slide, which showed that in the presence of an activating EGFR mutation in the first-line setting, clearly even the earlier generation EGFR TKIs were superior to carboplatin and paclitaxel, at least from a progression-free survival basis, and that was enough to lead to the approval of these drugs in the first instance. And in some contexts, we have overall survival data as well now. But I said these earlier generation drugs are going to become part of oncology history fairly soon, and that's because we know now quite a lot about mechanisms of resistance, and while some of those are relatively niche and need to be addressed accordingly with rather conventional therapies, for example, transformation to small cell histology. Fully half of patients who become resistant to the earlier generation members of this tyrosine kinase family have a resistance mechanism which is at least associated with a particular acquisition of a specific further tyrosine kinase domain mutation in EGFR, the replacement of threonine 790 by methionine. And this particular residue renders the oncogene resistant to the early generation drugs, but this newer therapy, third generation TKI, osimertinib, was specifically developed to be active even in the presence of that mutation. So we still have patients around who've done very well on the early generation drugs for a long time and now progressing. And in that context, we see whether we can identify the 50% that have acquired this resistance mutation, and then we offer them osimertinib. But if, and the drug is spectacularly active in that context in patients who've already had one bite of the cherry and been exposed to early generation drugs, have developed this resistance mutation, and then we see a spectacular response rate all over again in this context. So this was the so-called AURA study, which led to the approval of osimertinib in this context. So if a drug works in the second line setting, the next natural question to ask is, well, shouldn't we use it in the first line setting? And that's what the FLORA trial was all about, which again, I think is outside the scope of my quite superficial survey in this opening talk. Having said that, here is the result of that trial. So that's comparing with PFS as the primary endpoint, osimertinib with the dealer's choice of earlier generation TKI, and you can clearly see superiority here with a very spectacular hazard ratio of less than a half. So this is our standard of care drug now in patients with activating EGFR mutations identified at diagnosis. And of course, in the lung MDT, if you haven't been in one yet, you will bump up against molecular pathology, more to come again from Sanjay, as a standard of care. So it's not enough for us sitting in the medical oncology rows in that MDT to be told that the patient has a lung adenocarcinoma. We want to know what the molecular drivers are, if any, and EGFR is one, ALK is clearly an important other one. And ALK is generally a rather low profile gene product, which is active in a number of defined tissues, mostly embryologically, until it gets rearranged on the right here, and then its expression is upregulated and dysregulated and drives dedifferentiation and proliferation and inhibits apoptosis. So this is an important rearrangement to detect in lung cancer, and for more than a decade now, we've had access to a very active drugs, the first of which was crizotinib, with again an expanded phase 1 trial here showing spectacular response rate, which was enough without the traditional algorithm first going through later phase trials leading directly to accelerated approval of this drug based on a phase 1 trial in barely more than 100 patients. So again, a real dial moving intervention and study and drug, which has change the way in which we think about drug development, not just in lung cancer. And of course, those of you that are in lung clinics at the moment will know that crizotinib is kind of yesterday's news already, and a group of more active and less toxic therapies have moved in to replace it. Worth saying, just before we move on from crizotinib, that it is yet another example of reverse translation. So actually, crizotinib was invented as a MET inhibitor. And it was only through Ross Camage and his sharp-eyed investigators noticing that, again, like EGFR, if you took all comers with lung cancer, there were some spectacular super responders, and genomic analysis of their tumor revealed, in this case, rearrangement at this crizotinib gene. And so the trial was then retooled and redirected to recruit only patients with an ALK rearrangement, so that this spectacular activity was demonstrated in that very select population. So again, drug development, we as clinical drug developers tend to blunder into the clinic often with inadequate or incomplete biological data, and it's only actually running the trial which identifies the molecular drivers of our drug's activity. So that slightly breathless tour of epidemiology, conventional cytotoxic systemic therapy, and molecularly targeted therapies clears the decks for us to talk and concentrate for the rest of this discussion now on checkpoint inhibitors and other immunotherapies. And the reason that I've chosen to provide that emphasis is that immunotherapy, of course, you'd have to be living under a rock as an oncologist not to know that our entire practice and service design in many aspects has been transformed by the advent of successful and effective and sustained activity from immunotherapies. And much to many people's surprise, in the vanguard of all of those changes has been the lung clinic. So when I was coming towards the end of my specialist training and got more interested in lung cancer, I suppose in part because I'm not that old, even then, that some of these newer innovations were visible in the future, working in drug development as I was even then. But actually, that to the wider population, lung cancer was still regarded as being a bit of a Cinderella specialty, where a lot of our therapies were extremely palliative, even if we had some. And the fact that lung cancer has ended up, as I say, right in the front rank of solid tumors that have benefited from the early overtures of this immunotherapy revolution has been a huge surprise to many who sort of expected it to be really only the traditionally immune susceptible diseases like melanoma which would lead the way here. But actually many aspects of checkpoint inhibition, in particular patient selection using molecular biomarkers, lung cancer really leads the way in all of oncology. So just in case you are residing under said rock and you need a reminder on how checkpoint inhibitors work, I refer you to this very early and succinct and very clear mechanistic review in New England Journal, from which I've extracted this very simple cartoon. Well, if you don't know, you should, that T cells operate through antigen recognition in the context of MHC by their T cell receptor, but there are these second and other parallel signals which are required to modulate that response. And a key modulator of the response is recognition by the T cell receptor PD-1 of its ligand, which in a Darwinian way, many tumor cells are able to upregulate in order to push away activated T cells and survive the host immunity. So this is a clear targetable biological mechanism, and antibodies were duly developed which recognized either the PD-1 receptor or its ligand and interrupted the interaction between the two. And sure enough, release of T cell activation was the result, with some spectacular responses in animal models initially, and then surprisingly profound clinical impact straight out of the box in early phase trials in humans, where the increased complexity of the immune system, and certainly this synapse between T cells and tumors, is bristling with other molecules that are not shown on this highly simplified cartoon. You might not necessarily expect a measurable clinical impact from inhibiting only one of these interactions, but that is what we see in the clinic, of course. And this basic biology is what's unlocked a lot of the recent progress with checkpoint inhibitors. And every pharma has its own drug now, and this is just 4 of the earlier ones, which are most advanced in the clinic and all approved in one context or another. And you'll see for the antibody aficionados that there are a number of factors to take into account. So if you're targeting PD-1, the receptor on a T cell, you need to think about what your antibody looks like, because of course the Fc domain of an antibody is able to bind to Fc gamma receptors on further immune potentially damaging immune effector cells like natural killer cells. And so ideally, pembrolizumab, especially, and nivolumab are relatively ideal molecules. They are IgG4s, which is a subclass which is not very good at all at engaging with Fc gamma receptor. And so effectively what you're selecting out with this IgG4 therapy is the ability of these antibodies to kill cytotoxic tumor-specific T cells by engaging the patient's own natural killer cells. Obviously, that would be undesirable, and that can't happen given the smart selection of the right IgG. Anyway, I'm particularly interested in monoclonal antibody drug development, hence that little tangent, and come back and don't worry about it if I confused you there or you got lost. Back to some mainstream practice-changing clinical data. So I'm going to concentrate first of all in the straightforward situation where we know that PD-L1 staining levels are very high in our tumor, and we might expect these drugs to work. And that's been very much the underlying assumption, which has been validated in a whole series of randomized studies in lung cancer, that PD-L1 expression is kind of important. And I use my words carefully there. I'll explain why in a minute. So here, this is histologically all comers, and comparing with the relevant choice of chemotherapy depending on the histology. We talked about histology-specific cytotoxic drugs right at the beginning. And you can see, especially compared with the old generation of chemo versus chemo trials that we started with, a very spectacular divergence of survival curves here, and a hazard ratio bang on 0.5, in other words, a doubling of your chances of being progression-free at any given time. So spectacularly clinically as well as statistically significant. And so pembrolizumab is certainly an option in the first-line setting over and above chemotherapy. Remember, for the uninitiated, this is pembrolizumab single agent. It's not chemo plus and minus. So this is head-to-head single agent immunotherapy versus doublet chemotherapy. And it's clear which is the best one to have here. But we've also got another set of clinical experiments, and this is an example where we actually look at what I just described, combining chemotherapy with checkpoint inhibition. This is real medical oncology 101. If you've got a new drug, then why don't you start by adding into what you've got already? So that's not a bad idea either, as you see from these survival curves. So hazard ratio almost exactly the same, 0.49, in favor of the pembrolizumab chemotherapy combination compared with chemotherapy plus placebo. And this is in patients now irrespective of PD-L1 expression, as you will see in the little snapshot of the forest plot from this trial at the bottom. You can see that the patients benefit irrespective of PD-L1 expression now, rather like we see in other tumor types. and that's down to and including those who are PD-L1 negative, PD-L1 less than 1%, with an effect size very much favoring the pembrolizumab combination. So if I just flip back to the previous trial, you'll see that the quandary we now have. What if you've got a patient coming to your clinic, and I'll be meeting some in a minute this afternoon, who are PD-L1 high in the first-line setting? Do you give them pembrolizumab alone based on Keynote 24, or if they have an adenocarcinoma non-squamous histology, do you give them pembrolizumab in combination with chemotherapy based on this Keynote 189 trial? Well, that question is essentially unanswered because that randomized study is not yet and may never be done. So we have to pay our money and take our choice. Well, actually, as of earlier this year, we've got at least some non-randomized data to inform what we do. So this, just as an aside, was presented at something quite new called ESMO Plenary. ESMO, European Society of Medical Oncology, of course, has and had annual meetings like everybody else for many years, and then during this pandemic period has come up with this new concept, ESMO Plenary, where which really begins to challenge us, I suppose. The hard part about being an oncologist these days is just keeping up. And now, rather than having to wait for an annual ESMO, they're hitting us most months with an ESMO plenary set of presentations. If someone's got something big to say, then ESMO will consider allowing presentation, especially if you're Solange Peters, who's chair of ESMO at the moment, who presented this data just back in April. So this is the result of increasingly fashionable real-world analysis. So as soon as you see more than one survival curve on a chart and it's real-world data, you just have to keep reminding yourself that this is not a randomized comparison. So patients will have received either checkpoint immunotherapy, that's what CIT means, it's a horrible acronym, and I hope it doesn't catch on, because it could also mean chemoimmunotherapy, couldn't it, very easily, which would be very confusing. So CIT mono just means that's patients receiving checkpoint immunotherapy on its own, and then the combo is a combination with chemotherapy. And this rather messy survival curve here is messy because in color, as shaded color rather than dots and whiskers, they're trying to show us the confidence interval for two curves which are buried in those colors, if you can see them. And you can see it is actually quite hard to separate the curves because they're not separate. There's a non-significant p-value, and the hazard ratio is pretty adjacent to 1, as you can see in the bottom left-hand panel. So that's telling us that, allowing for the fact that there's maybe all sorts of selection biases in here, you pay your money and you take your choice, probably giving someone who's got a high level of PD-L1 expression. Single agent checkpoint inhibitor is not going to be inferior to giving them chemotherapy combination. And that seems to be the case, except for when you look at patients who have a history of never smoking. So you can see there in this bottom left panel that in never smokers, the analysis very much favors combination with chemotherapy. And that's readily rationalizable because these are patients who certainly don't have an EGFR or an ALK, etc. Mutation rearrangement, because those wouldn't have been eligible for first-line immunotherapy or checkpoint inhibition. They would have had a targeted drug. But they may be harboring some other single oncogene driver because they're never smokers, which has not been identified. And those sorts of tumors that are genetically rather bland, driven by a single oncogene, tend, we know, to do rather less well with immunotherapies because they're not bristling with neoantigens in the way that a smoking-related cancer is. So certainly in my practice here at Guy's, we're happy to use single-agent pembrolizumab in this patient group that is PD-L1 high, and leave out the chemotherapy unless we're really worried and want a quick response from somebody with proximal airway compromise or SVC obstruction or otherwise very symptomatic, because sometimes you just have to wait a bit for an immunotherapy response. For the increasingly small number of patients who get through first-line treatment without immunotherapy, and there are some who are not fit for combination treatment with PD-L1 low or no expression, we do have access to other drugs. For example, atezolizumab, again with a little forest plot here, is active irrespective of the level of PD-L1 expression. And I'm going to move now into some more general remarks and then close because we can't go on forever. This is important. So we've been running trials with these drugs in lung cancer for long enough now to get some pretty long follow-up. So this is 5-year follow-up data for Keynote-001, which of course is as the study acronym indicates, was the first pembrolizumab trial in lung cancer. And you can see there that there's this very clear plateauing of survival, so that if patients are alive at 2 and 3 years, they're very likely to be alive at 5 years, which is sort of conventionally agreed to be not far away from being a cure. So this sort of asymptotic to the x-axis survival curve that we're used to from the past, with really effectively no one alive at 5 years, we're seeing a dramatic change, at least for the small proportion of patients for whom this all works out. So when we're talking about measures of drug activity, I think we need to think differently from the past. So with more conventional anti-cancer treatments on the left here, we were looking to shift survival curves to the right. Generally, what we see with immunotherapies is maybe a bit of that, but often not very much. But and more prominently, a shift vertically in an upwards direction. And to express that in a number, we need something a bit different from medians. And so, for example, survivorship at a particular time point, 2, 3, 5 years, is quite useful. So you'll see that increasingly in trial outputs. So is immunotherapy completely fantastic? Well, every drug has its toxicity, and certainly immunotherapies have theirs, and they're well described, and you're probably pretty familiar with some of these, most especially commonly and most often worryingly colitis and hepatitis. And it's worth remembering this kind of kinetics. So this is a rather rough, but I think useful little mental picture to carry with you. Just because a patient is doing spectacularly well at 6 months doesn't mean that they haven't got quite significant diarrhea or and colitis, or even hepatotoxicity just around the corner. So do check your clinic bloods the next day. Make sure you're not missing, rapidly climbing transaminases in a patient who's otherwise been stable for months. I think this is worth thinking about when we quite often change from one schedule to another. Increasingly, we can use 6-weekly pembrolizumab at 400 milligrams, for example. Quite often, people say to me, "Oh, we were doing great till we stretched out the patient and gave them double the dose and half as often." Well, it just may be that our mantra for switching once patients are stable is all a bit back to front, because after 4 or 6 months we're growing in confidence and thinking the patient's well on the drug, but of course they're just entering tiger country from the point of view of onset of toxicity. So do bear that in mind. Where next for checkpoint inhibitors? Well, here's a sort of shopping list of progress, and we're gradually ticking these off. So certainly, since I first made this slide, we've addressed the issue of bringing these drugs for frontline, and most lung cancer patients now have one of these drugs frontline, either alone or in combination. So we've addressed that one too. What about early stage disease? Well, we can now strike that out, as I'll show you on the next slide. But we've still got some significant outstanding questions. How long do we need to give these drugs? 2 years. Is that enough? Is it too long? How frequently do we need to give these drugs? Can we come up with a better biomarker than PD-L1 shown at the bottom? What do we do at resistance? And there are some drugs coming through that look promising there. What about other targets other than PD-L1 and PD-1? And there are many, many of those in the clinic, and you'll probably hear about those from Martin Forster when he talks about phase 1 drugs in a minute. But addressing this issue about using drugs in the adjuvant setting, this is from ASCO a couple of days ago. So this is the first report of a positive study for adjuvant checkpoint inhibition with an immune checkpoint inhibitor. So this is atezolizumab versus best supportive care in patients who have surgery for their lung cancer and other adjuvant chemotherapy as would normally be indicated. And cutting to the chase, it was a positive study with a hazard ratio pretty interesting, less than 0.8. We'll have to see how this pans out. This is disease-free survival in patients in the stage grouping shown here in the title, which was the primary endpoint. With longer follow-up, we'll have to see how this pans out, but I think we'll be using these drugs pretty soon in the adjuvant setting, in addition to chemotherapy. So in the last couple of minutes, literally, I'm going to canter through 2 other diseases, having concentrated for all of this talk on non-small cell lung cancer, just because in a clinic near you, this is something else that's changed this year. So immune checkpoint inhibition front line in mesothelioma is here. And this was the Checkmate 743 trial, which was a pretty brave design, head-to-head pemetrexed cisplatin, which has been our standard of care for 20 years in this disease, first-line setting. Head-to-head against ipi-nivo, not in combination with chemotherapy, just immunotherapy doublet. And these are the important take-home results. So it was in all comers a positive study. So in epithelioid histology, the common one, the hazard ratio was 0.86, and of course this is a way of avoiding chemotherapy and the toxicities that go with it. In sarcomatoid disease, which is a very different histology, you can see the checkpoint inhibitors performed pretty much the same, but chemotherapy, as we know in this histology, performed extremely badly, and so we get this spectacular separation of curves and a hazard ratio below 0.5. And then the other, so this is clearly the way to go for a sarcomatoid meso, and we give it some thought in epithelioid, particularly if the patient wants to avoid chemo. And you'll see that PD-L1, although the trial really wasn't powered for this subgroup analysis, it looks like patients with a higher PD-L1 expression are the ones who enjoy the lion's share of the benefit from immunotherapy. So we've started routinely asking our pathologists for PD-L1 expression in our MDT, and for a patient with high PD-L1 or sarcomatoid histology, we would much rather offer the immunotherapy than the chemo. And this is, as we speak, accessible and funded, this doublet treatment, through an expanded access to medicine scheme, so-called EAMS, but this regimen is on the point of being approved in our jurisdiction, and paradoxically that EAMS, as you probably know, those have to close as soon as the drug is formally approved. But I think we fully expect nice and sort of formal CDF access to follow relatively quickly. So this has changed the standard of care here and now in the NHS. Final data slide for you. This is small cell and checkpoint inhibition, and you might be familiar with this trial, IMpower 133, using the Roche drug in combination with standard carboplatin etoposide chemotherapy. And you can see, again, statistically highly significant and a hazard ratio pretty attractive of 0.7 for the combination. So for fitter patients with small cell extensive stage disease, we offer this combination as a standard of care, and it's, again, funded in the NHS. So that was a bit of a lunchtime marathon. I hope that wasn't too much. Pretty superficial in places and bang up to the minute in others. So I tried to give it a little bit of a mix in that respect, and we covered a lot of ground from the very familiar now chemotherapy in advanced stage disease. We've had evidence for that really since the mid-1990s, meta-analysis. Adjuvant chemotherapy, of which more later this afternoon, molecular drivers, of which much more in a moment, and targeted therapies with them. Checkpoint inhibition has transformed care. I think that's one very definitive statement which no one would disagree with in the lung cancer world, in non-small cell lung cancer, and also now in mesothelioma and small cell. And I'll stop there, and I hope I've left enough time for any pressing questions.
Thank you very much, Professor, for the excellent talk and the very clear overview in such a limited time. There are a few questions from the attendees. First question is regarding deciding first-line pembrolizumab monotherapy versus combination with chemotherapy, and in those who are high PD-L1 expressors. And as you mentioned, you may assess whether you give combination regarding if you want to achieve a quick response. And the question is around what specific things you look to actually guide your decision. The tumor burden, or is there any marker for that, like LDH?
Yeah, so we addressed that a little bit as we went through, but I think it's an appropriate question to ask. Absolutely an appropriate question to ask, because it's one of the big unanswered questions really at the moment, and it faces us head on quite often. Just at the minute, I've talked about some of the things that we're concerned about for patients who are PD-L1 high and rather minimal symptoms, and can afford to wait for some benefit. Then I think there's very little to be gained from the addition of chemotherapy, as I've shown. And I think that, with all its limitations, I think the real world data that I shared with you from the ESMO plenary, I think is very helpful in reinforcing that prescribing behavior, which is, I think, is pretty universal now. But that doesn't mean that there's no room for the addition of chemotherapy in those patients. Just to emphasize, for patients with PD-L1 less than 50%, really single agent checkpoint inhibition is not adequate. So beginning to answer the question now, for a patient of whatever PD-L1 expression, if they're of borderline fitness, then less drugs are certainly better than more drugs. Patient who is PD-L1 less than 50%, I would rather give, I'm a bit worried about that, whether they're going to tolerate treatment. I would much rather give them carboplatin, pemetrexed, or carbotaxol, depending on histology, and keep the immunotherapy for second line. Similarly, in the well, I guess perhaps by contrast, in the group of patients who are PD-L1 high, we have almost the opposite dilemma. So for a patient who's got a lot of symptoms and his performance status is affected by the disease, we're in a bit of a quandary. We'd quite like to hit them with the triplet treatment, because they need a response quickly. If, for example, their LFTs are on the rise with liver mets, or they've got major thoracic disease causing symptoms. But those are the patients who are least likely to tolerate more drugs. So in that context, unless the patient was really right up against it, I would try and hold a steady hand on the wheel and give them single agent pembrolizumab, and hope that they have long enough to benefit.
Thank you very much.
Yeah, I mean, your ancillary question was a good one. Is there any objective measurement of tumor burden to throw into the equation here? I think the short answer is no. This is where it's a little bit of clinical nous and experience, and certainly getting the more experienced members of the team to meet the patient before making a treatment decision is key. It's not the kind of protocolized decision you can make in the MDT in the absence of the patient.
Thank you. Another question is whether you could expand on your thoughts on the engagement of the activatory versus inhibitory Fc receptors to enhance the checkpoint inhibitor actions and to engage the innate immune cells with actually like macrophages or NK cells.
Yeah, so now we're right off into orbit with sort of hypothetical and well, they're not hypotheticals, they're in the clinic already. These, you know, the newer rationales that you're alluding to, which are generating all sorts of complicated beasts from the point of view of new molecules. So I hope I emphasized as strongly as possible that very simple cartoon of PD1, PD-L1 as a second signal in T cells is a gross oversimplification, and that particular question obviously recognizes that fact. So bringing to bear more aspects of a therapeutic armamentarium, potentially all in the same molecule, is a way forward. So, for example, we can use bispecific antibodies to target both LAG3 and one aspect of the PD1 axis in order to select, you know, for T cells which are actually in the tumor rather than causing off-tumor toxicities elsewhere in the body. So these are the sorts of molecules that you might hear about from Martin Forster later on, benefiting from the explosion in sort of what I would call Meccano drug design. It's very feasible with monoclonal antibody technologies that you can construct a hybrid molecule with multiple specificities for more than one different target and achieve the sort of goals that your questioner was alluding to.
Excellent. I suppose actually that we have one last question for the interest of time. If Atezo actually comes to first line in PD-L1 high patients, where do you see this fitting into clinic compared to Pembro?
Yeah, I mean, it's very difficult without head-to-head studies, and I suppose we've been here before with lots of other drug classes, and generally speaking, the first drug in a class to arrive quite often retains quite a lot of the market. So unless there's a USP which allows a drug to leapfrog another, and in the absence which we're likely to be in the absence of a head-to-head comparison, that's it's quite hard to see pembrolizumab being displaced from its current dominance while we're still in the era of single agent checkpoint inhibitor or simple combinations of doublet platinum chemotherapy plus a checkpoint inhibitor. What's coming down the track, one hopes, of course, is some of the molecules we were just talking about. So moving on from simple PD1, PD-L1 targeting, and that's a little way off. And certainly you'll hear more from Martin, but it's safe to say that the spectacular activity straight out of the box of targeting PD1, PD-L1 doesn't seem to be immediately replicable in targeting other molecules in that immune synapse. So that's a bit of a work to be done. But as I say, these molecules are getting pretty smart now with multi-specificities, for example, as we were just speculating about. So that may be the future. I think for the time being, most of us perceive a sort of transient, how long is that measured in, small number of years at the very most, era of stability in the standard of care. So if you're feeling a bit breathless trying to keep up with even the basics of first line non-small cell lung cancer, which has changed so much in recent years, then you may not be too over-optimistic in hoping for an area of slightly less rapid progress, at least in the first line setting for the immediate future. But we'll see.
Excellent. Thank you very much. I think we don't have any time for other questions, so we'll just thank you very much, Professor Spicer, for your time today.
Thanks for having me.
Thank you.
Thanks very much, Cara and James. Really appreciate that and for sharing. And I'll let you get back to clinic. Thank you so much for taking the time out. Yes. It's with great pleasure I now introduce our next speaker, and we'll move straight into that talk. That's Professor Sanjay Popat from the Royal Marsden and the Institute of Cancer Research. His research interests lie within developing new treatments for thoracic malignancies and also in identifying new genomic variants for both the understanding how thoracic malignancies develop and also treatment strategies. He is also chair of BTOG, as well as many other hats I'm sure many of you will know, which I won't list off. I'll hand over to you, Sanjay, to go ahead with your talk on the role of genomics and targeted therapies in lung cancer.
Great, Dan. Thanks, and thanks to the organising committee for the invitation. It's a huge pleasure to be able to talk to all of you, and I'm very happy to take questions at the end of this. So I was asked to talk about genomics and targeted therapies, and I'm going to mainly focus on genomics, and I'll be very happy to give a talk on targeted therapies at another date, but you will hear about how this all works together. So these are my disclosures. So, I mean, the fundamental thing that we have learned over the past 20 years is how molecular genetics has revolutionized how we're treating our patients. And I remember being a young boy listening to the news when the first draft of the human genome was finally cracked and published in 2001, thinking, wow, this ain't going to change how I practice my practice. So I'm still going to be prescribing my platinum. But Time magazine was talking about pharmacogenomics and things like that. But I think we really are there now, and that's what I'm going to talk about in a lung cancer context. So to be able to understand this, we have to be able to appreciate that we have these human receptor protein tyrosine kinases, which are encoded within our genome, and these can be transmembrane receptors that sit on the cell surface with the kinase domain that you can see there, or they can be human cytoplasmic protein kinases, which exist within the nucleus or cytoplasm, depending on the particular type of kinase. And these are what we are essentially drugging to change cancer. So I would suggest that non-small cell lung cancer is a huge paradigm for genomic medicine. This is really what's driving a lot of the advances in many other cancers. And this is the sort of slide that I put up for my surgical colleagues most of the time. You have the pie chart on the left-hand side, which demonstrates the wide variety of genomic aberrations that we see in non-small cell lung cancer adenocarcinomas or non-squamous non-small cell lung cancer. And these are generally on events. These are genomic aberrations which switch on the kinase, which then drive and cause cell growth and division, which we all know about. And you can see that KRAS variants are, the vast majority of what we see, 25%. And depending on where you are in the world, your EGFR prevalence will be anywhere between 5% and 70%. But it actually gets way more complex than that, because, for example, in the simple world of EGFR mutant non-small cell lung cancer, you'll know on the right-hand side you've got the chromosome, and EGFR maps to chromosome 7p, and we're really only interested in the kinase domain variants, which map to exons 18, 19, 20, and 21, and that's what we're drugging. But actually, on the left-hand panel, we're actually looking at the individual alleles, because they are different diseases. So you have the common EGFR mutations, the deletion 19 or L858R, and that's basically what the vast majority of the trial data that we have is based on. But we have these other things which are rarer, called EGFR exon 20 insertions. We have the major uncommon mutations, such as G719X, which is an exon 18 mutation. We have the rare uncommon mutations, which you don't often see, L747P or S. You have a few people with de novo T790M, which is a exon 20 insertion. Then you can have compound mutations, which are combinations of all of these. And in the olden days, we never used to find these, because we were just doing a panel of PCR-based tests which tell you whether you have 1 out of 28 pre-specified mutations in the EGFR or not. Now, most of the time now, we've now moved over to broad NGS, where we're sequencing across the kinase domain. So we're picking these up, and the question is, how should we be managing them? And these can often give rise to some difficulties or questions. So we all know the concept is that within the nucleus you have a genomic aberration, which then results in a yellow receptor, one that is constitutively activated, therefore does not need the growth factor signal to cause the cell to divide, and you can give a simple tablet. The T on the right is what Roche use for their Tarceva brand to switch the kinase domain off. Now, we know on the left-hand panel that if you take a whole group of patients with non-small cell lung cancer adenocarcinoma, you can't really tell what type of disease it is. And so now These days we need to know the molecular aberration, and they are split into the different types of disease that we have. And on the right hand side, you can treat this like an infection in many respects, because you can have people with really quite widespread metastatic large volume disease, find the genomic aberration, within a few days they're feeling better, within 8 weeks they have another CT scan and their disease is almost gone. The problem that we have is that we have the reverse also occurring, which is at some point the disease relapses, hopefully not as bad as it started off in the first place if you're following your patients up carefully enough. That's called acquired resistance. And we have to understand who these patients are in the first place. We have to find them. Then we have to understand why they relapse. What is the acquired resistance, mutations or genomic aberrations or other reasons that are occurring, to then allow us to repeat that cycle and treat them again in a different manner. So when we're talking about acquired resistance, there are two concepts that I want you to understand. There are on-target and off-target acquired resistance mechanisms, and they can be broadly split into pharmacological and pharmacodynamic mechanisms. So pharmacological are things like, well, the patient has forgotten to take it for a while or refuses to take the drug. You can change the metabolism of the drug. Some idiot can put them on rifampicin. Some idiot can make sure that they're taking a proton pump inhibitor when they shouldn't be, because they interact with a lot of TKIs. Or the commonest reason is that the drug itself is actively pumped out by the endothelium around the brain, and so therefore there is inadequate CNS penetration of these drugs. The commonest things that we're seeing are these biological pharmacodynamic issues, which are either on the left-hand side, you've got an altered drug target, which is a on-target resistance mechanism, because you've got gene copy number of that target, which is overcoming the amount of pharmacological inhibition that you're giving, or the driver has changed to acquire a new somatic mutation, or you have on the right-hand side bypass track signaling. So you're blocking effectively driver A with your drug, but driver B pops up, which then allows the growth signal to be derived to the nucleus. So for example, a good example of this is in a patient with EGFR mutant lung cancer. We can take a patient with, for example, L858R mutation, treat them with afatinib, their widespread metastatic lung disease melts away, and then at some stage later they relapse, and we can then sample their tumor either by blood-based or tissue-based assays and confirm a gatekeeper mutation which prohibits the afatinib from binding, something called T790M. And then we can take that T790M together with L858R, give them a next generation inhibitor, osimertinib, which will clear that all up, and then they relapse again, and then we can work out what the biological resistance mechanism is, and in this case they've acquired MET amplification, and then we can then give them MET inhibitor, and hopefully we'll carry on going around that cycle. At least that's the theory. But to be able to do all of this, you have to understand the language of genomics, and I'm going to give you a bit of a primer about genomics. So the first thing is we don't talk about mutations often, we talk about variants, because when you see a variant, which is a change in the DNA sequence compared to the reference genome, remember what I was watching on TV in 2001? That's the reference genome. Then you know it's different to the reference genome. Now, a variant may or may not have an impact on the function of the gene, but we don't necessarily know, so we call everything a variant. If it's a benign or likely benign variant, it probably isn't going to have any impact whatsoever, and these are sometimes called polymorphisms. If it is a variant that's going to cause a problem with the function of the gene, we would call it a pathogenic or likely pathogenic variant, and in common parlance, this is what we call a mutation. So an L858R is actually the protein change due to a DNA variation, which is pathogenic, otherwise known as a mutation. Sometimes we don't know what the mutations do because there is no evidence, there's no data, and you can do what are called in silico analyses, and they work out that, well, it might cause an effect, but it might not cause an effect. So these are what we call VUSs, variants of unknown significance. And this is when we don't know what change it occurs, what change it causes in the gene to make the gene either silent or activating. not necessarily whether it's druggable or not. Remember, druggability is a completely different ballgame to whether the gene is switched on or switched off. And over time, your VS will change. Your VOS may not be unknown in 10 years' time. So you have to understand that genomics is a moving landscape. Then we need to talk about the types of variants that we have. We have the SNVs, the single nucleotide variants. This is when the reference sequence changes by one nucleotide. You have the structural variants, where the structure of the gene changes. So gene rearrangement is a good example, such as an ALK fusion. And then you have the copy number variants, where you can have the normal variation within the gene, but just lots and lots and lots of that gene. And that's a good example of that is your ERB2 or HER2 amplification. So I'm going to tell you how to read a report, because most of the trainees I come across don't look at the reports. They don't know how to read a report. They just look at the strap line. So here's how you read a report. You have to understand the Human Genome Variation Society nomenclature, HGVS. That states that you give the name of the gene first. Here's an example, BRAF. Then you give the nucleotide change, reference to the coding DNA. So you look at the reference DNA. Remember what I was looking at the TV in 2001? You take that, get rid of all of the introns, which is the crap that you're not so worried about. So it's just the coding sequence. And you go to position 1799, and there the nucleotide T has changed to an A. Okay? And then you have to work out what results occur in the protein due to that nucleotide change. And here we see that the P, which is protein, so it means that the P results in a change of V600E, which means a valine at the 600 codon changes to a glutamine. Okay, so that's what that code means. And you hear these other things, sometimes seen. Del means deletion, dup means duplication, ins means insertion, inversion, frame shift. These are all different types of signs that you see. There are different types of mutation. There are things called a silent mutation, so it doesn't change the amino acid. So for example, as in the reference sequence, CGT changed to CGC. That still changes an arginine to an arginine. It may have no effect whatsoever. It may have a huge effect, but it may have no effect whatsoever. Then there's the missense variants, which change the amino acid. GTA to GAA results in a valine changing to glutamic acid. Big difference. Nonsense changes. It inserts a stop codon, TCA to TAA. And frame shifts changes the nucleotides, which are then not divisible by 3, so it changes the protein sequence. Then it may change it quite considerably or introduce an early stop sequence. So here's some examples. Let's say this is the reference DNA sequence, a single nucleotide variant, CT4 to C means at position 4, 1, 2, 3, 4, T has changed to C. You can see that? Hopefully you can. Then there's this, which is an insertion at C4, 4 ins A. So position 4, 1, 2, 3, 4, you've inserted an A. Then you've got a deletion, C4 del T. So position 4, T has been deleted. And then you've got an indel, or an insertion and deletion. So C4 del ins CCG, 1, 2, 3, 4, you delete what you've got at position 4 and insert CCG. And then you've got the same thing for the duplication here, where you're inserting CG at position 4, and so on and henceforth. Now, the reason that this is important is the NHS published this important document called Improving Outcomes Through Personalised Medicine, which has established a genomic medicine service within the UK. There are now 7 funded genomic laboratory factories, otherwise known as laboratory hubs, and it's commissioned whole genome sequencing for PEDS, sarcomas, and some heme cancers as well. It also mandates that all patients should give some sort of consent for genetic testing. I bet you're not doing that now. You will be, mark my words, in the future. Maybe you won't be, but we'll go into that in a minute. And it's formed what's called a test directory, which mandates this is what the NHS is genes that they will genotype for a particular cancer. It suggested that you should dedicate frozen samples for genotyping over FFP. That's really not practical, but that's what they want us to do. And it's mandated we should have genomic tumour advisory boards and molecular tumour boards to discuss cases. So in lung cancer, this is quite important, because if you look at the list of the FDA-approved therapies and MHRA therapies and therapies around the corner, which we may be able to access through compassionate use schemes or pre-licensed schemes, we now need to genotype all of these particular markers for lung cancer to be able to give our patients the best chance. So that's quite a lot of genotyping we've got to do for our advanced non-small cell lung cancers. Unfortunately, in the NHS test directory, which you can download, it's in the public domain, you can search in the Excel spreadsheet for non-small cell lung cancer. The vast majority of these are funded. So if your patients are not getting MET testing or RET testing, you need to ring up your lab to find out why not, because it's funded. And there may be politics for why those samples aren't getting there, but it's funded within the NHS, and all these laboratory hubs have processes to take samples from elsewhere. So how should you be doing it? Well, in the olden days, we used to do single gene testing. We looked at 1 or 2 genes, and then we said, well, let's look at KRAS, because if they got KRAS, then they definitely haven't got EGFR or ALK, and that costs a little bit more if you're going to do it that way. But actually, the cheapest way of doing it, once you start looking at 7+ genes, is NGS, and that's what the NHS has mandated. And this, this is one health economic paper confirming the cost utility of that. But biomarker testing in lung cancer, and I would argue many other cancers, is actually quite complex. One of our genomic scientists said to me, it's not rocket science. I said, yes, it is. Actually, it's quite complex, because you've got a patient who's waiting with a diagnosis of cancer. They've probably been waiting about 2 months to get through the diagnostic process, if not longer. And then they may see a chest physician, told them they've got cancer, or they may see an oncologist, told them they've got cancer, and you say, yeah, that's fine, but I tell you what I'm going to treat you with in three weeks' time or 2 weeks' time. And that's really not an ideal scenario. You've got to get the specimen from the patient in the first place, and then the specimen has got to get to the lab, it's got to get analysed, and then the report's got to reach the oncologist. Now, there are several issues here. Who orders the molecular tests? Is it the oncologist? Well, the oncologist never met the patient. Is it the chest physician? Well, the chest physician doesn't know anything about genomics usually. Is it the pathologist? Well, the pathologist's got the specimen, so I would suggest it's a pathologist, but the pathologist may not know what you as an oncologist want for that particular specimen. How long does it take to get the tissue from the place where the pathology lab is to where the molecular lab is? It can take quite a long time. If you tell the pathologist you want to do it today, but the pathologist doesn't fill in the form till Thursday, then puts it on the in tray of the path secretary on Friday, then you've lost a whole week for that patient before the tumours even left the path department. Where is the tissue? It can be in a very different place to where you expect it to be. Then there's the bit about the analysis. Well, the mission is sort of accomplished there, and then who gets the report? So that can be quite complex, because the person that's ordered the test may not necessarily know who the receiving oncologist is. So we can do lots of tests. We can do single gene tests, which are great, but they waste DNA and they give false negatives. You can do NGS by DNA, which is superb. It's very good, efficient use of DNA, but it's very good for single nucleotide variants, but it's very slow. Have issues with detection of fusion and problems with clinical annotation. What do these variants mean? Really, you want to be doing a combination of DNA and RNA. RNA is the gold standard for structural variants, but you get very poor quality RNA from FFP, and it's quite slow. Immunohistochemistry is fast and quick, but you can get false negatives. You can sometimes get false positives. FISH used to be a gold standard, but it's extremely slow. It doesn't tell you the break point, doesn't tell you the fusion partner. And it's really not what we're using these days. Then you can go into liquid. You can do liquid ctDNA for a single gene test like EGFR, which is great. It's fast, but it has lots of false negatives. And you can do ctDNA NGS, but it's not NHS funded. It's fast, but it's less fast than the single gene test. There are issues about its coverage and false negatives and false positives as well. And it doesn't pick up fusions particularly well. So ideally, you want to be doing a combination of DNA and RNA for lung cancer, and I would argue for every other tumour type as well. And that's certainly what we're doing in our hub here at the Marsden, which covers the North Thames patch. And this is based on data from the US, where in the US, the Memorial Sloan Kettering They took the DNA panel, which is their impact panel. They took patients who didn't have a driver, put them on an RNA panel, and basically showed that there's a whole bunch of drivers that were detected by RNA and not DNA. And that's not surprising because these are often splice site variants or fusions with intronic boundaries, which may not map to where your DNA is going to be tested. So just because you get a wild type result on your DNA test doesn't mean to say the patient hasn't got an actionable variant. So you've got to be really careful about false negatives. How should NGS be done? Well, there are guidelines from various societies, and we now have a recommendation from the AMP about tiering. So we should really be talking about our mutations as tier 1 variants, level A or level B, tier 1A or tier 1B. Tier 1A are FDA or MHRA approved drugs, and 1B are drugs which aren't yet regulatory approved, but we know they work. Tier 2 are variants of potential significance. So for example, P53, I can't drug it yet, but I know it's important. Tier 3 is a variant of unknown significance. So a BRAF variant, I have no idea what that does. The databases don't tell me what it does. And tier 4 variants, which we either know or think are going to be benign. And that's really important, but the important thing you need to know is that your variant of unknown significance today may become a tier 1B variant in about 3 years' time, and your patient may be alive. So make sure you have an understanding of what their full molecular profile is and how you can access that. ESMO have issued similar guidance on genotyping as well, and they've got a very similar tiering scale called the SACT scale. So the bigger question I keep getting asked is, how do you handle germline findings? Because you're sequencing the tumor, but the tumor is part of what that individual is, and you'll inevitably pick up germline findings. You can do what most people in labs do now currently, which is stick your head in the sand and ignore the problem and hope it will go away, but it won't go away, and we have various guidelines as to how we should be handling this. First of all, we should be informing patients that when they have tumor testing, that there's a chance we might find germline information. Ideally, we want to be consenting patients, and that's what the NHS is saying. And so if you've not met the patient and yet they've had their gene testing, who's doing their consenting? It's probably going to be the chest physician. Does the chest physician really have this knowledge to be able to appropriately consent them for this? And we need to be able to make sure that we can respect the patient's wishes, ideally, whether they want to know or not, and we need to be really careful not to overcall a somatic variant as germline. So patient's got somatic BRCA variant, somebody goes down a rabbit hole of calling it germline. So here's an example. This is a patient of mine with mesothelioma that we ended up doing comprehensive NGS on for various reasons, and the patient's got a variant in BAP1, a PQ272 star. So that's a stop mutation variant, which causes a stop sequence, a truncating variant in BAP1 at a variant allele frequency of 24. So that's a classical pathogenic variant in mesothelioma. No surprises there. It's somatic because the variant allele frequency is quite low. However, patients also got BRCA2 variant. It's a synonymous variant. That's the nucleotide change, and I know it's likely going to be germline because it's got a high variant allele frequency. So that patient then has to be referred to clinical genetics. However, the NHS says that clinical genetics will not see patients with an off-target variant. So most clinical genetic services will say, well, mesothelioma BRCA testing is not funded in the NHS. So you've then got a problem as to what you do. Fortunately, our colleagues were happy to see him and test him. So when you get a variant, how do you know what it means? Well, these are the databases I use, and I encourage you to do the same. Dr. Google knows everything if you can find it, so just stick your variant into Google and see what it comes up with. PubMed is excellent because most variants have been reported before. And case reports are really, really important. So those of you that think case reports are a waste of time, write up a case with an unusual variant. It will get cited, it will be used by people in the field. In the world of lung, there is the uncommon EGFR mutations.com database, which is very good for looking at the effectiveness of afatinib. Then you've got larger databases. OncoKB is probably the gold standard. This is the Memorial Impact database, which gives very good AMP tiering together with druggability. Franklin is very good for germline variant interpretation. Cosmic will tell you what your somatic variant does, and ClinVar will categorize, mainly germline, all of your variants. So you'll say to me, well, look, this is, all very good, but actually tumor genotyping is over. I'm a believer in blood. Liquid is the way forward. And you may be right, but liquids introduce all sorts of complexities. So for example, liquids are brilliant. So we're talking about ctDNA NGS is brilliant because it will tell you about what you find in the plasma, not just the one lesion that you're sampling, because heterogeneity is really important, particularly on acquired drug resistance. You may not have a resistance gene variant in that particular metastasis that you are biopsying, but it may be present in many others, and you might pick it up on ctDNA. However, when you're doing ctDNA analysis, you've got to remember you are genotyping 3 genomes. You're genotyping the tumor genome, you're genotyping the germline genome, because there'll be some from the white cells, and you're also genotyping the heme genome from the other white cells. So you've got to be careful about what are called chip mutations or clonal hematopoiesis of indeterminate potential mutations. These are variants which may cause hematological malignancy or in some patients, or may just occur as sequence variants as patients naturally age. They're just normal variants. I would suggest in lung cancer we're moving to blood first, and there are many studies. We've got one of the largest studies which we presented at the VTOG meeting recently, where we took new patients and they were genotyped in parallel with tissue and commercial ctDNA. And what we find is that the false negative rate is much higher for tissue than it is for liquid. And there are many potential reasons for that. And liquid is much faster than tissue NGS, because you can just take a simple blood draw and send it to a commercial company for genotyping. So if we're going to use this, how do we best use it? I would suggest that it should be used at diagnosis. The question is who's going to pay for it. The NHS currently isn't. It should definitely be used in target identification at acquired resistance, but if you haven't found something, doesn't mean to say it's not there. So you may need to follow that up with a tissue biopsy. And some people would argue maybe you should be doing ctDNA NGS as you're trying to confirm they've got cancer in the first place. So at the same time you're putting the needle into their lung cancer, you're taking the blood draw. So when you have a diagnosis of lung cancer, you have the ctDNA readout there at all. You also know that people who clear ctDNA have much better survival. This is progression-free survival in people that have cleared ctDNA and EGFR treated with EGFR inhibitor than people who haven't cleared their ctDNA. So it may give us a predictive value to consolidate our treatments, and that's what we're looking at trials in the future. So I'm going to stop here and say that genomic medicine's here to stay. You've all got to learn the language of genomics. NGS is standard and will get more complex, so you're lucky because you're going to be brought up with the language of all of this. And we need to use tissue and ctDNA in target identification all of the time, and we don't really know how ctDNA is going to work in the future. So I'm going to close there. Happy to take any questions, but I've got some cases which I'm happy to go through as well if folk want later.
It's great. Thanks very much, Sanjay. So there is one question that's just come in. So first of all, thanks for a great talk. And what are the implications of the Matrix trial on the practice of precision oncology within lung cancer?
Yeah, so Matrix is basically a large national trial where we took all patients with lung cancer and we NGS'd them in a very standard homogeneized manner rather than a variety of lab developed tests. We did them in a central CR UK funded validated assay, and we identified that some targets are highly sensitive to TKIs and some targets are not. So basically what it's shown is that drugging some targets in lung cancer is actually quite complex, and drugging other targets in lung cancer is pretty straightforward. And the other main message is don't believe the hype that pharma tell you about how good their drug is, because actually there's a lot of redundancy within the cell system. So if you have one particular somatic target and you switch that off, you'll just upregulate other processes to take that growth signal, which is why you may not get a very high response rate. But it's a very good platform to try and work out what the right pairing of genomic aberration with drug is, because often that's not very well known for some of the higher hanging fruit of the genomic targets, such as, for example, rare EGFR variants. We have no idea what osimertinib does to these rare variants.
Great. I've got questions as well. You had a great slide on the limitations of some of these tests that we have access to. So thanks for that. I'm sure many of us will be going back to that later to recap. You talked about ctDNA as well as a useful tool for monitoring acquired resistance after therapy. So I had a patient in Guy's who had small cell transformation as well as T790M mutation. And of course, these are extremely rare. But is there a chance we're going to miss these kind of patients by not doing biopsies?
Absolutely, and that's one of the key issues of using ctDNA in the acquired resistance setting. So it's got many roles, and this is what we need to work out. It's definitely got a role in blood first at the time of diagnosis. It's much quicker than waiting for tissue, but we're not there yet. So at the moment, we're still using tissue at time of diagnosis to do our NGS. Then you drug your patient with a TKI, they'll then get acquired resistance. So NGS is good, but NGS will only tell you about the sequence variants that ctDNA ingest, that will pick up. You've got to remember that you will have histological change. Small cell lung cancer, neuroendocrine transformation is one of them. We often see when we biopsy these patients a change from adeno to squame or large cell neuroendocrine type of phenotype coming through. Much more EMT going on in these patients as they develop acquired resistance. And if you want to change your treatment, you may want to do both tissue and liquid. The issue of small cell is quite unique because you usually know that it's a small cell because you're not expecting it to grow quickly, and then you do a CT and go, wow, where did that come from? That's small cell. But you've got to remember, if you don't find a variant on ctDNA, just say you find a P53, well, you've missed something perhaps, because your ctDNA is not very good at picking up your gene fusions. It's not very good at picking up your ROS, your RET, your ALK. Particularly if you've got small volume disease on board. So ctDNA works brilliantly when it finds something, but always be very skeptical that it may have missed something.
Great. There's a kind of follow-up question from Sophie about acquired resistance. So is there a role for intermittent dosing of TKIs to slow down or interrupt acquired resistance, do you think?
Yeah, it's a good question. I mean, we don't really know is the answer to that question. I mean, there's preclinical data which seems to suggest that that might be useful. And there's several papers which have done these in various cell line and xenograft models which have demonstrated that. We've tried that previously in one trial in the EGFR field, something called the SACT trial, published in the JCO many years now. And this was a trial of chemotherapy with pulse dose TKI, and essentially the pulse dosing TKI didn't really change the outcome at all. So we've sort of gone away from that and just keep to the standard model of if you're going to use your TKI, just use it continuously. There's always a worry about flare, and flare is a real problem with TKIs. So they've got very good data on this, which my colleagues at Memorial in New York showed in the early days of EGFR TKIs. If you take a patient and they've progressed and you stop their TKI and do a PET 2 weeks and 6 weeks after, you see PET flare at 2 weeks and you see growth at 6 weeks after. And that's all to do with the half-life, because the half-life is around 2 weeks, so you're losing your ability to mutation at that point, and then you're getting some growth. And in about a third of patients, that would be clinically significant growth. So there are concerns about not being on TKIs all the time.
And again, another question on the same kind of topic. So this is from Ben. So Will there be a role of dose escalation in overcoming acquired resistance for those secondary to copy number alterations?
Yeah, it's a good question. So we don't know is the answer. I suspect probably not, because if you look at the way we develop TKIs, we don't develop them for their recommended phase 2 dose at the dose that's the PD dose, at the dose that causes a pharmacodynamic effect. We develop it at the maximum tolerated dose. So, I mean, a good example of this is in the early days of EGFR inhibition. I mean, we use the standard dose of erlotinib at 150 a day, don't we? Yeah. So why do we use that? Because it's the maximum tolerated dose. It's not the dose that you need to switch off your EGFR mutation, because that dose is much lower. It's about 50 actually. We use gefitinib at a much lower dose, 250 a day, and that's probably a dose that's causing PD, but the maximum tolerated dose is 750. We're not using that dose, and people have always been worried that they're not dosing their gefitinib patients adequately enough at 250 a day. The problem with copy number change is we don't really know how much dose you need to overcome it, and none of the data we've seen so far in individual cases has shown a meaningful effect, and then you start running into tolerability problems.
Great. And there's another question from Karina Owens. So with the newer targetable mutations, do you think there's more of a role now for NGS in the squamous and smoker non-small cell setting?
Definitely, 100%. Every single patient should be getting NGS, okay? Take home nothing from this talk. Take home that every single patient should be getting NGS. Right, so all the action's happening in adenocarcinoma, right? But your needle is going into a tiny little bit, and the sample you're taking out is tiny. So actually, you're not sampling the whole of the tumor. So there are many, many cases of mixed tumors, adenocarcinoma, squamous cell carcinoma, where all you're getting is a squame. You're thinking, doesn't make sense. Actually, it's an adenosquame. Definitely got to do NGS. And even in a smoking squame, we've got BRAF, very low prevalence, but it does occur V600E. We've got KRAS, the non-G12, well, G12C occurs very rarely in smoking squamous cell carcinomas, but you have many other non-G12C KRAS variants occurring there as well. So you're not going to find your EGFRs and ALKs in your smoking squames, but you're going to find other things. You know, for example, FGFR fusions, very, very rare, but where are they going to occur? They're most likely going to occur in your squames than there are in your adenos.
That's great. Thanks very much, Sanjay. I think we're coming up to time, so I think rather than move on to the cases, we'll leave it there because I know you've got some other commitments.
Yeah.
But thank you very much for taking the time to join us. We really appreciate your time, and thank you for coming to speak to us. Take care.
So I'm Mark, so I'm Medical Oncology Reg at Imperial. So it gives me great pleasure to introduce Dr. Tom Newsom-Davis. So Tom is a medical oncology consultant at Chelsea and Westminster. He treats a range of thoracic malignancies, including non-small cell, small cell, and mesothelioma. He also set up and runs our acute oncology service at Chelsea and Westminster and West Middlesex Hospital. And he's going to give us a great talk, I'm sure, on neoadjuvant and adjuvant treatments in non-small cell lung cancer. Over to you, Tom.
Thanks, Mark. Welcome to the glories of the Chelsea Westminster Clinic room. It's pretty special. No windows. Here we are. This is me. Anyone interested in thoracic malignancy, here comes a hard sell. Do think about joining the British Thoracic Oncology Group, BTOG, down the bottom there, which I have the honour and pleasure of being part of. It's a great organisation, and we've got lots of stuff focused at the trainees. So here are my disclosures. Make of them what you will. Right, so when we're thinking about adjuvant treatments, and in fact neoadjuvant treatments, I kind of wondered what maybe we should be trying to achieve. And essentially there's three possibilities, aren't there? The first of which is you eliminate the residual disease. The other of which is you control it, but you don't get rid of it. And the third one is your treatments don't work. And if you have those, roughly your outcomes are this. If you eliminate it, you're going to cure them, whatever that means. If you control it, you'll delay the recurrence, but you're not going to cure them. And if they have no effect, you've actually overtreated them with the best of intentions, but you have overtreated them. So it's often worth thinking about that. And whilst we're thinking about that, we should say, well, how on earth do we assess, therefore, the benefit of an adjuvant treatment? Now, the gold standard, which all of our friends in ESMO and ASCO get very excited about, is overall survival. And if you want to be flogging your adjuvant treatment and you want to prove that adjuvant treatment works, well, then you want to be proving a overall survival benefit. But that's quite difficult to get. It takes a long time. It can be lost as you have crossover in trials, you have a heterogeneous patient population, your trial finishes early and it's underpowered, maybe you don't get overall survival. So we often use surrogate endpoints instead. Disease-free survival, relapse-free survival, event-free survival. And the advocates of this say, well, this is brilliant, this is a way of demonstrating benefit without having to wait for so long, because you and I have to make treatment decisions in clinic before overall survival matures. And the cynics will say, well, look, there's no point giving adjuvant treatment unless you're allowing people to live longer. And one can argue the point either way. And of course, one of the most important things is cost effectiveness. It's all very well having benefits of outcome, but what's the cost, financial cost, to healthcare and to the patient? So I thought we might break it down into the old school. First of all, we're going to go chemo. So adjuvant or neoadjuvant chemotherapy. And this used to be the most boring talk to give in oncology. I'll be absolutely honest with you. I used to give it the MSc years ago, and you can dragging up these studies from ages ago, and they weren't very interesting, and nothing had changed. But you guys have absolutely nailed it, asking for this subject today, because a whole slew of data has come out from ASCO last weekend. I'm sure you were all plugged into that instead of down the park. Adjuvant and neoadjuvant is really a big focus of lung cancer now. So that's great news for you, but it did mean that yesterday, on my birthday evening, I was writing these slides instead of doing something more exciting, which is very sad. So lesson number 1 of adjuvant chemotherapy goes back to 1995, when I was but a third-year medical student. And what was done there was a meta-analysis in the BMJ, and it looked at adjuvant chemotherapy regimens. And lesson number 1 for adjuvant chemo was you need a platinum. So here we have what is now called a forest plot. It wasn't called that before. And on the top 2 bands with the big red X's, we have non-platinum based chemotherapies. And if you look at the hazard ratios in the forest plot on the right, you will see there's either no benefit, in fact, detrimental effect of alkylating agents in the top group of studies, or no significant benefit in the middle group of studies, suggesting giving adjuvant chemotherapy with those containing drugs is not beneficial. But lo and behold, if you give platinum-based chemotherapies, and there are about 8 studies there, you can see there is a slight benefit. I don't know if you can see my mouse, but there's a slight benefit in terms of overall survival for people receiving platinum-based chemotherapy. So it's been a comparatively recent thing that we could actually even prove that adjuvant chemo was beneficial, but platinum was the way forward. Lesson 2 was you needed LACE, and LACE is a meta-analysis, the lung adjuvant chemotherapy analysis or something like that. And this came after the data I've shown you, and it looked at 5 trials after 1995. And here are the regimens listed. Have a quick read through those. And most of you are going to go, yep, vinorelbine cisplatin, I know what that is. And a couple are going to go MVP, I think I've heard of that. And then you're going to go vindazine and vinblastine. What on earth are you talking about? So quite a range of different chemotherapies were looked at in this meta-analysis, reflecting the approach people were taking to adjuvant chemo at that point. When you look at these results, bear in mind, in the analysis, 10% of patients never got chemo, and about a quarter only received 1 or 2 treatments. So it's not an easy treatment to give. Lung cancer patients are older. They don't feel very well after someone has chopped out part of their lung. Please also really focus on the bottom line there. So 2/3 of patients gave 3/4 toxicity. 1% of patients had a grade 5 or fatal complication. So if you're going to be giving adjuvant chemotherapy, about 1% of your patients are going to die. Now, that's not a reason not to do it, but it is a reason to be careful about giving it and give it to the right people. Now, what did LACE show? Well, LACE looked at 5 studies listed in the middle there, ALPI, ANITA, BLT, IALT, and JBR10. On the left, you've got forest plots of disease-free survival. On the right, you've got overall survival, and you can see there is a benefit, both of disease-free survival with an overall hazard ratio in the red box of 0.84 and ditto overall survival hazard ratio of 0.89. And this really, when this came out and the final publication was 2008, this really was the time when people said, I think adjuvant chemotherapy is worth giving, because the meta-analysis they used on these 5 studies were proper big phase 3 studies. And as you can see, there's over 4,500 patients included in this meta-analysis. So who benefits from adjuvant chemotherapy? Well, it's one of the first things I learned about lung oncology, 5% at 5 years. That's really the benefit. Overall, someone walking through the door, about a 5% increase in overall survival after 5 years, shown by McCaplin-Meyer on the left there. But have a look at this graph on the right. It's really important. It's a bit small. I hope you can see it, but it's really important because it tells you really who you should be giving adjuvant chemotherapy to and who you shouldn't. The top one is talking about the different drug combinations. They found out very quickly the one to give is cisplatin vinorelbine with that hazard ratio furthest to the left there. And so that's the one we should be going for. Don't give other drugs and don't give 3 drugs. Lesson number 3. Other lessons are, if you're going to give it, give a decent dose of platinum. You need over 300 milligrams per meter squared over the course of the chemo, which is why most regimens are 75 to 80 per cycle. Don't dose reduce them unless you have to. Certainly don't dose reduce them without seeing what the first cycle is like, because you significantly lose benefit. Skipping down a little bit, you can see that patients over 70, there's a very wide confidence interval, and it's a little bit less clear where there is benefit in that patient group. There's actually very few people over 70 and almost no patients over 75. So if you meet someone who's 80 or 85 and you're thinking about adjuvant chemo, it's not a reason not to give it, but you're almost without evidence base of the benefit of it. So be a little bit more careful in those patient groups, and definitely don't give adjuvant chemo to people who aren't well. So PS2 patients, there weren't that many in the study, but you can see that the hazard ratio is properly in the don't give them chemo direction. So you need to be PS01. If someone's struggling to recover from surgery, they're PS2, they should not be having adjuvant chemotherapy. And I've learned to my cost that is very much the case. And the last thing I want to point out is that the benefit of adjuvant chemotherapy is dependent a bit on stage of disease, as you can see in the kind of penultimate group there. The early stage patients benefiting a little bit less, and the stage 2 and indeed the stage 3 patients benefiting a bit more. In fact, the benefit for the stage 3s is probably nearer 10% than 5% survival. So that's adjuvant chemo. And in my book, getting back to my rather simplified diagram of what on earth does it all mean? Well, what it all means is that you do cure people with adjuvant chemotherapy, but choose your patients and choose them carefully. So I'm just going to check I can be heard. Can I just double check everything is clear? And slides are changing when I think they're changing.
Yeah, that's absolutely fine, Tom.
Excellent, thank you. So that's adjuvant chemotherapy, much excitement. Not the most exciting part, if truth be told, of giving lung oncology treatments, but we do it. What about neoadjuvant chemotherapy, beloved of, for example, breast oncologists, I believe? So there are 4 main large randomized controlled trials of neoadjuvant chemotherapy, and I've listed them for your convenience in this excellent slide. These are big studies, 500, 200, 600, big studies, international, multi-center, European, American. These are the kind of the big hitters of the late 2000s. And you can see they use some platinums with the EIT studies, GemCis or carbotaxol, kind of regimens that we would have some familiarity with. But you will see with a surge of disappointment that actually they all, not all, many of them closed early. And you have it closed early because of poor accrual. That's a massive impact on how you can assess the data. Usually means it ends up being underpowered, and you be very careful drawing any analysis. But actually, the long and short of it was that there was no difference in overall survival in the European studies. There was some improvement, perhaps, in overall survival in the CHESS study, but because it closed early and as preliminary data, it didn't hit statistical significance. A small improvement in overall survival in the NATCH study, but again, the hazard ratio is not particularly great, 0.96, and an improvement in hazard ratio in the American SWOG study, but again, not reaching statistical significance. Now, what you do, of course, when you've got a bunch of studies that don't quite hit the target is you do meta-analysis, hide a multitude of sins. And this was done by colleagues in 2006, 7 studies, including the ones I've just shown you, over a 15-year period. And they found an overall hazard ratio for neoadjuvant chemotherapy of about 0.82, and your incremental overall survival benefit is written down there on the left. And you can see that is very similar to about the 5% of adjuvant. So you might be thinking, why on earth don't we give neoadjuvant chemo more? Well, there are some caveats. The data is largely favourable, but actually individual studies were often borderline statistical significance. Now, many of them were flawed. They didn't recruit properly, they recruited slowly, with preliminary results, they weren't often had quite poor baseline investigations. But largely, I think the benefits are comparable with adjuvant chemo. It's quite a heterogeneous group, the neoadjuvant group. The adjuvant group, in fact, to get through surgery to have the chemo, the neoadjuvants have a more heterogeneous group. But you might want to think about maybe there's a downstaging perhaps in about 50% of patients, but a pathological complete response rate, and I want you to remember this number, please, of around 5%. I said 5 to 10 is probably nearer 5%. Neoadjuvant chemo is not recommended necessarily in ESMO guidelines, and most European American centres tend to follow adjuvant chemo instead. Just remember, the neoadjuvant is not giving treatment to make someone operable. It's already decided they are operable. You're giving the chemotherapy in front to improve outcome, just to make that point. So yeah, I think neoadjuvant chemo probably does cure people. And I think probably whether you get neoadjuvant or adjuvant doesn't make a massive amount of difference. I stick to adjuvant because this is what the consensus is, and probably where the better and stronger data is, although there's not a huge amount of difference between the two approaches. So lung cancer, as you know, is the poster boy of the targeted therapy. And those of you who are lucky enough to have done lung oncology jobs, for example, Ravindi, high point of her career so far, will love the enjoyment we have of throwing around EGFR, TKIs, and ALK and ROS1, and it is why it is by far the most interesting speciality of all of oncology, and there is no argument in that at all. Of course, those drugs are restricted so far to the metastatic setting, and we have ALK patients 5, 6, 7, 8, 9 years on ALK inhibitors, and we have EGFR patients 2, 3, 4 years on treatment, and it's wonderful. What about adjuvantly? What about neoadjuvantly? Well, there's a bunch of studies which I've listed for your convenience on the left here. So just remember, targeted therapy is in non-small cell lung cancer. It's always in non-small cell. It's nearly always in adenocarcinomas, very rarely in other types. And here are the range of targets that we look at. And in red are the ones we have licensed available treatments for at the moment in your local oncology clinic. And in purple are the ones where treatments are coming through very soon, or indeed available already through compassionate access programs. So this is quite an important part of what we do. So number one, can we give EGFR inhibitors instead of adjuvant chemo? I've already told you that 1% of adjuvant patients may have a grade 5 toxicity. It's a tough treatment to give. Vinorelbine cisplatin is not very nice. You feel sick, it knackers your kidneys, you get peripheral neuropathy. Can I give my amazing EGFR inhibitors and instead of chemo and therefore make the patient feel better? So there's one study called the Adjuvant study, can't remember why they called it that, presented at ASCO last year. There's a study called the Impact study, presented at ASCO this year. This is the quality of data that I'm providing you, ladies and gentlemen. And you might be thinking, well, hang on, Tom's obviously a bit sleep deprived because he was up all night preparing slides for this magnificent talk. And yet he's made the mistake of putting the same trial design and almost exactly the same study population in the two trials. But no, I am not mistaken. These are actually incredibly similar studies. One largely based in more in the Southeast Asia of the world, and Impact a little bit more in the West, but very, very similar designs. EGFR mutated lung cancer, completely resected, give them adjuvant chemo or give them gefitinib. Gefitinib, you will know, is the first generation EGFR inhibitor, not one we use anymore in the metastatic setting. It's very much been superseded by the second and third generation drugs. So what is the outcome of giving gefitinib instead of adjuvant chemotherapy? Well, you can see the two studies there. So Impact is the top line, Adjuvant is the bottom line. you can see there's an improvement, in disease-free survival. So look at the left-hand two graphs first, please, if you could. You will see in the red line where the TKIs were given for the first 2 years, and you can see there's an improvement in disease-free survival. Isn't this fantastic? So the curves separate, and they separate early. But they come back together, and they come back together by about year 4, so 48 months into that. And we've seen that actually with other adjuvant studies as well. There's 1 or 2 others I haven't included, including a study called SELECT. So it appears to be delaying things, not getting rid of things. And in fact, if you look at the overall survival, you could not get your laser pointer really between those 2 curves. So the long and short of this is that if you give adjuvant TKIs instead of chemo, well, you're not curing people, you're probably just delaying it. Now, one very important question is, well, if I give my adjuvant chemotherapy, adjuvant TKI, does that mean I cannot use that TKI when they relapse to advanced stage disease? Well, that probably isn't the case. This is a really complicated graph. I hate these kind of ones, those ridiculous dotted lines. But look at the very top blue line there, the best performing one. Those are people in the impact study, I think it was. No, it was in the adjuvant study, sorry. Which got their adjuvant TKI, and then when they relapsed, they also got a TKI again, as we would now do anyway, and they do the best. So you can re-challenge with a TKI, you're not preventing people getting that, but despite that fact, you're not actually making people live longer if you give them a TKI instead of chemo. So it delays, it doesn't prevent recurrence, no increase in overall survival. The data I haven't shown you here. With gefitinib, it doesn't protect the brain either. So this definitely comes into a slightly disappointing amber. Delays doesn't cure. Not licensed in this setting. So it paves the way for ADAURA. ADAURA was the big news of ASCO 2020 and set the exciting folk of lung cancer Twitter afire for many a month. So this is similar to what we've just seen. These guys have been resected. Stage 1B, this is the old staging, so 4 centimeter tumor or bigger, or stage 2 or 3A, which means they've got lymph node involvement. So tumor more than 4 centimeters and or lymph node involvement. EGFR mutations, the common ones, the exon 19 deletions and the L858Rs. Good nick, complete resection, and they get adjuvant chemo as decided by the oncologist. So if the oncologist was going to give chemo, which was platinum based, they got that, and after that, they were randomized to osimertinib or placebo. Primary endpoint, disease-free survival. So there are a couple of important things to say about this. So this is EGFR TKIs in addition to chemo, not instead of chemo. And the other important thing, which I put in big red arrows so I didn't forget to tell you, is that this study was unblinded early because of the very clear benefit in terms of disease-free survival. And so we have an unplanned analysis I'm going to be showing you. And that puts the cat among the pigeons because it's unblinded. And that means the study's never going to recruit to its full planned number. And it's going to have an impact on overall survival in the future because you can be sure as damn it, if you found out you're on placebo, you'd be busy switching yourself onto osimertinib. So this is the money shot of the study, and it is a spectacular disease-free survival improvement. Osimertinib in the blue, yellow is the placebo. Now, some of you might be treating breast cancer and you'll say, well, we see this kind of hazard ratio all the time. It's absolutely standard. This is unheard of in lung cancer. Hazard ratio of 0.17. So an 83% reduction in the chances of recurrence. It's amazing, absolutely amazing. From very, very early on, all the way through. Now, there wasn't an overall survival benefit shown by little tiny graph here. Well, at least not a statistically significant one, but you will remember study was unblinded early. This is an interim analysis, and we're probably not going to see a benefit because everyone's busy switching off the drug once they found what they were really on. So massive DFS benefit in patients with stage 2 or 3A disease. This does not include the patients with just stage 1B disease. Who benefited from it? Well, pretty much everyone, apart from the stage 1B patients, so those are lymph node negative, just a tumor over 4 centimeters. And really there, I think the benefit is much less clear. And the confidence interval is pretty much close to the median line. But apart from that, most people benefiting to the same degree. There was a suggestion that L858R mutation patients might have done a little bit less well. There was a little bit of a suggestion maybe that Asian patients were doing a little bit less well, but actually I think you can't really hang much on that. And I would say the benefit was pretty much across the board. And interestingly, there was no adverse effect on quality of life. Ozi is quite an easy drug to take. 11% discontinuation rate sounds quite high, but for a treatment you took for 2 years, actually that's not bad at all. And the other important thing is if you look at the patterns of relapse, patients on Ozi had much less relapse, full stop, hence the smaller, slightly horrible greeny blue color in down those various sites, but really importantly, it protected the brain as well. Brain metastasis is a truly awful event for anyone, and osimertinib was preventing brain and systemic relapse. So what's my conclusions on ADAURA? Unprecedented disease-free survival benefit, CNS activity, it's safe, it's well tolerated, but will this massive DFS benefit translate into overall survival? And if it doesn't, will we believe this is an appropriate treatment if we can't show overall survival benefit? Will the unblinding muck up the results? I think it probably will. What duration of osimertinib is needed? 2 years. It's an expensive drug. Expensive drug. It's 4 or 5 grand a month. It's so much as Ravinda earns. It's outrageous. And if we're going to be committing that for 2 years, is that really money well spent? What will longer term data follow up? And actually, if Ozi is so marvelous, can we get rid of chemo? Well, I'm not so sure about that. This falls into the, I think it's going to cure people, but I can't quite tell you yet. So I slightly hedge my bets by putting my red arrow between the yellows and the greens. But I think we will see an overall survival benefit. Personally, I think that DFS hazard ratio of 0.01 is so magnificent that it will translate into an OS benefit too. What about neoadjuvant EGFR? So far it's just been adjuvant. What about neoadjuvant? So there's one study called the Emerging Study. This is a Chinese study, CTONG 1103. And this is a slightly different approach in that they're taking patients who are treatment naive, stage 3AN2. So they've got stage 3 disease with essentially mediastinal lymph node involvement. They've all got EGFR mutations. They're all in good nick. They randomized them to start erlotinib, you'll remember is one of the first generation EGFR inhibitors, or GemCis as a neoadjuvant treatment. And they basically get that for the best part of 6 weeks. And then, assuming they haven't progressed, they have their surgery, and then their adjuvant treatment is erlotinib or chemo. So you're having a neoadjuvant bit and an adjuvant bit. And the primary endpoint is overall response rate, which is not necessarily the most useful primary endpoint one could imagine. What the emerging study showed was there is a progression-free survival benefit. You can see that in the top graph there, the green, erlotinib's doing better than the chemos, but it does not translate to an overall survival benefit. And they said in a hazard ratio of 0.83, and a bit of fuss was made about that in ASCO, as was presented a few days ago, but it's not statistically significant. So I think this comes into the delays recurrence bit, reinforcing that if you're going to be doing TKIs, it's got to be in addition to your chemo, not instead of. And I think the role of neoadjuvant TKIs remains an unproven phenomenon. So what's my thoughts overall on TKIs in the neoadjuvant or the adjuvant setting? Number one, really important fact, they do not replace adjuvant chemo, I'm sorry to say. If you've got an EGFR mutated patient who you think you might be teeing up for some adjuvant osimertinib, give the chemo if you're going to be doing that anyway. Adjuvant osimertinib is the standard of care. And I put that in brackets because it depends a little bit on your point of view. A lot of early adopters would believe that. It is now licensed, and certainly in the US, a lot of people are doing it. There are some others who would say, I'm not going to do that until I can see an overall survival benefit. You can choose your sides. Personally, I think it probably is. It's easy to poo-poo a disease-free survival benefit when you're sitting in the hall in ASCO. It's a bit more difficult when you've got a patient in front of you who's 45 with EGFR mutated lung cancer, and you're saying, well, I've got this drug which has an 83% chance of reducing the chance of cancer coming back, but I haven't seen the overall survival yet, so I'm not going to give it to you. I'm a little bit uncomfortable about that. You need CNS penetration, so if you're going to give your TKI, you're going to give Ozi. And the other important thing is that TKIs do still seem to work if the patient does relapse. But I think we've seen from the early studies, the adjuvant study and the impact study, that DFS does not always mean increase in overall survival. So we should be skeptical of disease-free survival as the only marker of activity. Neoadjuvant immunotherapy is the really hot topic from ASCO and is the last thing I'm going to talk about. The high point of the plenary session of ASCO was IMpower 110. These are patients with what we normally give adjuvant chemotherapy to. So these are more than 4 centimeter tumors with lymph node involvement or lymph node involvement. They get adjuvant platinum-based chemotherapy with the range of drugs that you can see there, and they're randomized to either atezolizumab or they are randomized to best supportive care. Okay, note a couple of things. This is a big study, 1,200 patients. There is no crossover, but it's also not placebo-controlled. And your primary endpoints, the thing you're mainly basing your statistical analysis on, is disease-free survival, investigator assessed. Okay, so this is the first proper phase 3 of adjuvant immunotherapy. You can bet your bottom dollar, of course, there are a number of other phase 3s looking at the other immunotherapy agents, and they have yet to be released. And this came out as the first of the plenaries in ASCO. So this is, again, the money shot. This is in a complicated design where they did something called a hierarchical statistical analysis, which is a way mainly of confusing you and me, but it's a way of them trying to pick out what they believe to be the most relevant patient group, and then going through that, and if there's a statistically significant improvement in the primary endpoint there, you then go on to the next patient group and the next patient group. A cynic might say it's a way of hiding from showing your overall survival data, which you might never be able to prove, and picking out on your DFS data, which is easier, but that might be a bit cynical to say. But the headline news is that if you have a PD-L1 positive, more than 1% or more, non-small cell lung cancer, which is stage 2 or 3A, in other words, there's lymph node involvement, hilar or mediastinal, adjuvant immunotherapy improves your disease-free survival, and it does it early doors. It does it from really much the beginning, somewhere between 3 and 6 months into treatment, your DFS is improving. A hazard ratio of 0.66, statistically significant, and you can see the improvements in DFS across the bottom there at roughly, 15 or 13% at 2 years and 12% at 3 years. So this is great stuff. And this is really the first time this has been shown in a, so I'm slightly fiddling with a little thing showing me. So this is kind of the first time that this has been shown in a phase 3 study for adjuvant treatment. Much excitement, much whooping in the aisles. What about the subgroups? So I love a forest plot, brilliant, aren't they? Tell you everything you need to know. So there's a couple of things to pick out in this. Number one is look at the, so I'm just trying to get the picture of myself out of the way, there we go. Looking at the bottom right-hand side, you can see the EGFR patients and the ALK patients. The ALK patients, not very many of them, very wide confidence intervals. They don't appear to be doing so well. You can see above that regional lymph node involvement. You can see people without lymph node involvement not deriving so much benefit from the atezo as patients with lymph node involvement. That's not surprising. More advanced stage disease patients, greater chance of relapse, presumably greater benefit of immunotherapy. Interestingly, and I can't explain this, I haven't found anyone who can yet, looking bottom left-hand side, you can see current smokers appear to be benefiting less with adjuvant atezo than others, and I really don't have an explanation of that. And there's a possible suggestion your squames deriving less benefit from adjuvant atezo than the non-squames, although I think it's fair to say there's a lot of overlap in those confidence intervals. So the next group they looked at, just to go back up one, after they looked at the PD-L1 positive stage 2 to 3As, that was their top group. The next group they looked at was everyone they randomized, so PD-L1 positive and negative, in the stage 2 to 3A patients. And I want you to look at the box in red. That's why I colored it in red, so you look at it. And what you can see, the middle one there, where it says TC 1% or more, hazard ratio 0.66, that's what I've just shown you in the Kaplan-Meier a couple of seconds ago. That is that group doing really well. And then you can see of your PD-L1 high, and TC is tissue components, that's basically to you mean PD-L1 status. So PD-L1 over 50%, these guys are doing really well. Hazard ratio 0.43, whereas the PD-L1 negatives really aren't gaining benefit. Look at the hazard ratio, it's pretty much bang on one line. So that says to us that adjuvant atezo, this is really key, adjuvant atezolizumab is benefiting your PD-L1 positives, it's not benefiting your PD-L1 negatives. And my take on it is the PD-L1 highs are really carrying that benefit. Now what they haven't presented, and I'm sure you've worked this out already, is a PD-L1 1 to 50%. What about the low positives? Well, we don't know that, and they haven't told us that. And you may want to interpret that whichever way you want. with the big exclamation marks to remind me to say, do not give adjuvant tislelizumab if you're EGFR positive or ALK positive, because it doesn't seem to work. Fitting in with the fact that immunotherapy does not work well for this type of lung cancer. What about overall survival? Well, this was an interim analysis, so you're not going to get mature data. And because as a hierarchical testing went down, the significance was lost on different groups, they did not do a formal assessment of overall survival, and the data is immature. But if you want to be positive, and we should always be positive, you might say in that PD-L1 positive stage 2 to 3A patients, there is a separation of curves. There is an OS benefit there. Hazard ratio 0.77. I think I might take that. So that is exciting for this patient group. What about neoadjuvant immunotherapy, giving it beforehand? So the high point of AACR 2021 and ASCO this year was CheckMate 816. This is using nivolumab. So these are the guys who are going to be having their treatment, their neoadjuvant therapy before surgery. Same patient group, more than 4 centimeter tumor and or lymph node positive. This time they exclude the EGFR and ALK patients, which seems sensible. And they either got chemo up front or they got chemo and nivolumab. And they got that for 3 cycles. And if they hadn't progressed, they moved on to surgery. And then to make their lives really complicated, they then said, oh, you could also give adjuvant chemo or maybe adjuvant radiotherapy, which is going to make analyzing the results quite difficult. So this is neoadjuvant chemoimmunotherapy, CheckMate 816. So the headline results from AACR was this, which is that if you give neoadjuvant chemoimmunotherapy, you have a significantly raised pathological complete response rate and a significantly raised major pathological response compared to chemo alone. And this is on the back of a bunch of phase 1 and phase 2 studies I haven't shown you, which have said neoadjuvant immunotherapy looks like it gives a bit of a PCR and a bit of an MPR result, but neoadjuvant chemoimmuno does that even more. But this is the first phase 3 study to show it, which is why it's included. But the elephant in the room, which is why there's a red elephant there, the red elephant in the room, there ain't no survival data. This is all pathological response. Now, we know that PCR and MPR correlate with chemo to survival. We don't know that's the case with immunotherapy yet. And so we don't have survival data. What we found at ASCO was the significantly improved pathological complete response by stage. And you can see in the green, the chemoimmunos getting much more PCR than the chemos. And the depth of response is also much better with the chemoimmunos compared to the chemos as well. So I don't think there's any doubt that chemoimmunotherapy is a better approach than chemotherapy alone neoadjuvantly. There's some really interesting data surgically came out as well. Always a concern, they're going to give chemoimmuno. Maybe they won't finish the chemo, maybe they'll get some immunotox, maybe they won't get surgery. Quite the opposite. So the left-hand side, all the green stuff on the left there is all the chemoimmuno arm, all the right stuff is a chemo arm. Look at the completed cycle, the kind of top right and top left box. So guys on the chemoimmuno did better, more people finished their treatment. And look at the cancelled surgeries. Actually, fewer people on chemoimmuno failed to have surgery. More people had surgery on chemoimmuno. And in fact, the duration of surgery, surgeons apparently measure their operation times, who knew, was less, suggesting fewer complications. And in fact, that's borne out in other data. If you had neoadjuvant chemoimmunotherapy, they had fewer thoracotomies, fewer open surgery, more minimally invasive surgery, like that, fewer pneumonectomies. Don't want a pneumonectomy, terrible thing. There was no difference in how in R0, 1 or 2 resection. In other words, there did not appear to be more residual disease with chemoimmunotherapy. There was no increase in surgical complication rates and correspondingly no difference in length of stay. So what are my thoughts on neo or adjuvant immunotherapies? Well, atezolizumab adjuvantly, are you a DFS believer? I mean, if you are, then you're going to be reaching for your adjuvant atezolizumab when it's licensed. I will hasten to add it's not licensed yet. If you're an OS believer, you're going to be saying, well, I'm not so sure about that. But I think adjuvant immuno is interesting because I think we will end up curing some people with immunotherapy. I think it's a bit different to a TKI. And there is something about the immunological memory which makes me just wonder whether we might be able to to achieve that. I think the benefits driven by the PD-L1 high, the strong positive, over 50% of people. I don't know the benefit in the 1 to 49%, and no one's shown it to us yet, and that is not good. I would not be giving adjuvant atezo to PD-L1 negatives. No benefit, that's pretty clear. And I would certainly wouldn't be giving it to the EGFR mutation or the ALK translocations. The neoadjuvant stuff, I think there's a clear pathological benefit. And I think what's really interesting now is it's not detrimental to surgery. We can reassure our surgical friends about that. But I think we need survival data before that changes practice. So it's a race, ladies and gentlemen, a race between the adjuvant data, atezo, and there are adjuvant studies for Pembro, for nivolumab, and for Durva, none of which will surprise you, and the race between those four, but also the race between the other neoadjuvant studies, of which there are many, and they will be producing their data in the next 2 to 3 years. So adjuvant atezo, yeah, do you know what? I'm going to put my money where my mouth is and say I think there is cure. I've slightly chickened out, and I pulled the red arrow down a little bit to the lower part of the green, just so I don't look like a complete idiot in 2 years when I've got it completely wrong. And I think probably safe for neoadjuvant. I think this is going to change what we do. I think we will be giving neoadjuvant or adjuvant immunotherapy in some form to our patients. And I think this is a permanent change in how we treat our lung cancer patients, which is marvelous. So what are my conclusions? My conclusions are adjuvant chemotherapy remains a standard of care. If you want to stand clear from lung MDT, and Max knows what a bang on about now lung MDT is, if the tumour's over 4 centimetres and lymph nodes are positive, you want to consider adjuvant chemo. But with those caveats I showed you in the latest meta-analysis, it ain't for everyone. It's not for the elderly. It's not for people with dodgy performance status. It's not for someone who's struggled to recover from surgery. Adjuvant osimertinib improves outcomes for EGFR mutation patients. Personally, if it was a relative of mine, I think I'll be getting out my Aussie. Adjuvant atezolizumab improves DFS in the PD-L1 positives only. Who knows about OS? But I think that is probably going to change what we do in the years to come. And neoadjuvant chemoimmunotherapy, I think you need both. I think you need the chemo and the immunotherapy. We know it's safe and effective now. We just don't know what the survival is. You're very welcome to follow me on Twitter. It's very exciting, and I'm very happy to take any questions.
Great, thanks, Tom. That's a really excellent presentation, very succinct, and a great summary from ASCO as well. So I'm sure everyone appreciated that. So just in the interest of time, we probably have time for a couple of quick questions. The question hotline has been very active as well. So we have a question from was it Benjamin, who says, are we potentially over-treating EGFR mutant patients with adjuvant treatment then? We showed no benefits with adjuvant gefitinib versus chemo, but we haven't done a trial of adjuvant Aussie single agent versus Aussie chemo adjuvantly versus placebo. What are your thoughts?
Yeah, I think you're absolutely right, and they're not going to do that because it's too expensive. I think you may be over-treating them, and I think we know from all these things you could be over-treating someone. Aussie is not an entirely straightforward drug. It does cause, can cause cardiac effects. It can cause pneumonitis. I think there is a big difference between first-generation drugs and osimertinib. It is a vastly better drug. I mean, no one uses gefitinib anymore, so I hope they don't. And I think that difference in activity does change the paradigm of what we do. I think brain protection is really key. I mean, brain mets are awful. And I'm enormously impressed by my clinical oncology colleagues and what they can achieve with SRS, but it's still ghastly. So I think if you can protect the brain and you've got a DFS of 0.17, I find that quite difficult to ignore. And if I overtreat a bit, I think that's okay. And I'm reassured by the fact that if they do relapse, I can still use the drug again. The slight caveat to that is that at the moment, NHS funding for osimertinib is no prior TKIs. So although the evidence is you can re-challenge, NHS funding might preclude that.
Great. And Dan has 2 questions, so we'll just go for one of his. So he said, what are your thoughts on separating the trials based on population, probably racial demographics? Seems to be driven by recruitment in the TKI setting, or is there any good biological justification for this over having multiple multi-center studies?
Yeah, I think that's a brilliant question, Dan. I think there is definitely a difference in response to particularly targeted agents according to racial heritage. We know that a lot of the trials, I couldn't show you, but they are actually, some of the stratifications are according to region of recruitment. And some of the big caveats particularly for IMpower 10, was there was quite a big representation from Caucasian and Asian, but there was a less than 2% Black Afro-Caribbean patient population. There's a real disquiet, particularly in the States, about where these studies are tending to recruit from, about that lack of focus on other on patient groups. So I think it would be nice to do that. Trouble is, the more you break the studies down into small subgroups, the more you dilute the statistical significance of the results you find. But I think there will be a difference. I think in the end, we're probably going to end up treating everyone a little bit the same based on what the overall opinion from the trial is.
Great. So I'm sure anyone that has another question can probably DM you on Twitter or just email you.
Yeah, £500 an answer, it's bargain. You can probably put it in tax return.
Great. No worries, but thanks for an excellent presentation.
That's my pleasure. Thank you very much. We're going to go back to clinic.
No worries.
Thanks, Tom. Take care.
Thank you.
So I'm just going to hand over to Alison, who's going to introduce our last speaker of today's session, Dr. Martin Forster from UCL.
Thanks, Dan. My name's Alison Berner. I'm an ST5 medical oncology trainee in the UCLH rotation, and I'd like to introduce Dr. Martin Forster, who is an associate professor at UCL and consultant medical oncologist at University College Hospital, who specialises in thoracic and head and neck cancers and has a particular interest in drug development. And he runs a research-based practice, being principal investigator or chief investigator for over 50 early and late phase clinical trials. He collaborates broadly, nationally and internationally, and is involved in translational research. He's also joint lead for clinical trials, the clinical trials theme of Cancer Research UK Lung Cancer Centre of Excellence. Today he's going to speak to us about early phase trials in lung cancer.
Thanks, Alison, and thanks everyone, and thanks for the opportunity to speak about early phase trials. It looks like you've had a really interesting afternoon. I was also in clinic and wasn't able to listen, but you've had some really good speakers. So hopefully you're not all just looking at the sun, wanting to be out there. I won't keep you for too long. I actually changed pretty much entirely what I thought I was going to speak about when I realised who I was following, because I know that Tom is such a good presenter, and I suddenly realised that giving you a whole list of early phase studies with lots of drugs with numbers, not even names, most of which will go nowhere, probably wasn't going to be that interesting. So I've tried to put it into context and try to tie in all the sort of information that I imagine that you'll have heard from earlier on, in context of both Sanjay and James in particular, around targeted therapies and immunotherapy, and thinking about what's next and how have the development of those understanding of cancer biology really, and the translation of that into drug development to give a different perspective on how that works. So hopefully it'll be interesting, and we'll have some time for some questions later. So just to put it into context, when I was first getting interested in oncology, these were the sorts of data that were being shared with me by Sanjay and others when I was first looking at lung talks. And there was endless studies randomizing between different platinum doublet arms, all of which were showing really no difference at all. You can't even get a wafer between those Kaplan-Meier lines. So, really not looking very inspirational at all. But things have gone totally bonkers, as you know, and in lung cancer, even more so than most other tumor types. And in trial design and clinical studies, that's true as well. So we've now got phase 1 studies which have got thousands of patients in them. And pretty much all of the checkpoint inhibitor phase 1 studies have got more than 1,000 patients in. We've got such a race to report that phase 3 pivotal practice-changing registration studies are being presented at AACR or SITC or other sorts of smaller meetings. And we've got registration of new targeted therapies from early phase studies. So really the kind of concept, and in some ways, you as the new generation of oncologists are going to have to take on the mantle that we've been trying to do about educating regulatory bodies about different drugs, how they work, different patient populations, so that they do recognize that an OS might be a very important landmark for chemotherapy or immunotherapy, but it's not the right thing for a TKI, and likewise, nor is a 1,000-patient study. In fact, again, when I was training, the sorts of targeted therapies that were being explored, EGFR therapies in particular in lung cancer in the unselected patient population, again, thousands of patients being treated with EGFR inhibitors, either as monotherapy or with chemotherapy, with really no benefit seen, certainly nothing clinically meaningful. So of course the revolution, and I'm not embarrassed to show you data. It's a bit of a cheat when I'm supposed to be giving you early phase studies, new early phase studies, and this is a decade old and a phase 3 trial. But just putting into context again, the idea. I think this is a really important study conceptually. When we start thinking about, this was a patient population that had been selected. It was delivered in the Far East, adenocarcinomas, never or light smokers. So really selecting all the clinical characteristics that we recognise would make most likely to respond to gefitinib as it is, but an EGFR targeted therapy, not selected by their biology, but recognising that EGFR expression and potentially mutation were important biomarkers, and that was being collected. And then when you look at the actual trial outcome data, the practice changing data is of course the EGFR mutation positive patients on the left, and you can see a hazard ratio of 0.5, very impressive data, led to license around the world. But I think the really important message that was also there and is not so spoken about is the graph on the right, which showed that even if you had all of those clinical characteristics, which meant that clinically we would have predicted you'd done well, if you didn't have the biology, you had a hazard ratio of 2.85. So you did miserably badly if you got the targeted therapy and you didn't have the right biology. And I think that's such a pivotal point when it comes to recognizing the importance of cancer biology when it comes to these targeted therapies. And I know Sanjay's, I think, spoken to you about these already early on today. So I'm not going to dwell too much on the history or the current therapies. But of course, the beauty of the current paradigm shift in science is the ability to understand the biology better, and this concept of reverse translation, recognizing that with first or second generation EGFR inhibitors, more than half the patients would get secondary resistance through T790M exon 20 resistance mutation development as under treatment pressure. And that led to conversations with the chemists that led to the development of drugs that were active against that specific population of tumor cells. And so, you know, really clever science, which of course then led to the clinic. And I should point out that Iressa or gefitinib, that took more than 10 years from first in human evaluation to getting licensed in 2010 for EGFR mutant lung cancer. So, and along the way, at least twice, it was threatened to being the development being stopped altogether. Whereas by understanding the biology, by developing the right drug, here we see the osimertinib data. Again, it's not new data, but from the phase 1 and pooled phase 2 data, a few hundred patients, we saw in less than 5 years from first in human to license. So by understanding the biology, by developing the right drug and selecting the right patients, you can expose a small number of patients to a treatment and get accelerated approval of a novel agent. And you've just heard from Tom how that's now rolled forward into first line and even now adjuvant settings. So, of course, sadly, even osimertinib doesn't cure anyone of their disease. And what the next step is, well, how do you understand about resistance to osimertinib? What do we know about that? And interestingly, and perhaps not surprisingly, resistance to OSI is different in the first line setting to the second line setting, because in the second line setting, you've already developed T790M, and therefore, when you develop resistance to that, you can either lose that T790M mutation, which is often associated with a worse outcome and often associated with other signaling pathways being activated, and less likely to have EGFR-driven resistance. But in the first line setting, you've never developed that T790M. Actually, it's less common that the primary resistance is through EGFR mechanisms. So it's quite complex, and there's quite a lot of various different mechanisms of resistance. MET is clearly a very important one, particularly in the second line setting. Sorry, but is very important in both. Other signaling pathways, fusion events are present quite frequently as well. So thinking about that in a clinical perspective or in context of a drug development, you're looking at somewhere between sort of 20% and a third of patients having some sort of EGFR resistance driven mechanism of resistance, and the rest having some degree of other sort of signaling pathway activation to bypass that effect. And so you can imagine that many of these different resistance pathways have had work done on them in the lab and indeed in the clinic. And so there's a whole host of studies now looking at combining osimertinib with different inhibitors of those, particularly of those other pathways. MET particularly of interest. Most of these studies I haven't got a lot of data for yet because they're ongoing. Many of them looking at either in resistance, some of them looking in the first line setting, but most of them in the second line setting, with a number of different pathway inhibitors. And then a few studies more generically looking at anti-angiogenic drugs. We've seen before that bevacizumab seems to potentiate other EGFR inhibitors very well. So there's work looking at that in resistance, looking at chemotherapy combination with OSI. We've again seen chemotherapy with earlier generation EGFR inhibitors being very tolerable, as well as other sort of pseudo chemotherapies, if you like, such as the anti-apoptotic agents and PARP inhibitors. So lots of work going on in early phase studies, ongoing still really, nothing jumping out from those at the moment. Although one of the drugs which is really quite interesting from a drug development perspective, and from a, I suppose from a pharmacy perspective, or from a pharmacology perspective, is amivantamab. And this is a bispecific antibody, EGFR and MET, which was developed to be active against EGFR activating mutations, but also T790M, and also secondary resistance mutations in EGFR, the most common of which is the C797S, and also has activity against other EGFR de novo resistance mutations, which are usually insertions in exon 20. So it has lots of different activity against different components of EGFR mutant disease. And also, because of this bispecific activity against MET, has activity in MET amplification. So this is in phase 1 study at the moment, and is being looked at first in various different settings in a phase 1/2 study, and that's called the Chrysalis study. And it has a dose finding study, and then it's now in expansion, and it's got multiple different cohorts looking in different settings, some of them in EGFR resistance, EGFR activated disease with resistance, single agent, some of them in combinations. But the study which has been presented earlier this year is looking at that EGFR exon 20 resistant mutation driven population. This is now an expansion cohort for patients who've had platinum-based chemotherapy, so it's a second-line treatment for this patient population, which is becoming one of the most difficult, because you meet never-smoking patients and you look for EGFR and ALK and ROS1 and RET and other, and if you pick up an EGFR exon 20 resistance mutation, we all groan, because it's, you know, there are some sort of fairly blunt targeted therapies out there which don't work very well and which are very toxic, and we're in desperate need of a drug which works for this cohort of patients. So this is an expansion population now in the phase 1 study, which was presented at the World Lung earlier this year, and we can see here a pretty impressive looking waterfall plot with activity and disease shrinkage in most patients. And that's across all different different mutations. There's quite a lot of different mutations you can get in exon 20, and within this study, there's around about 20 odd different mutations described. And given the fact that there's less than 100 patients, that's quite a lot. But you see activity across all of those. I think it's quite cheeky that they call it 100% activity in the mutations in the helical region when there was only one patient, but still activity across all parts of these really resilient resistance mutations. When it comes to tolerability, it's what you would expect. So you get EGFR-driven toxicity, which is particularly rash. And you can see here that a small number, but some patients had to discontinue treatment because of rash. You can see that the vast bulk of the treatment-related toxicities are low grade, with only a very small number being grade 3 or above. But we also know that patients who are on treatment for these sorts of these targeted therapies can be on treatment for quite a long time, and therefore actually the even relatively low grade toxicity can be quite a burden. So we have to see how this is going to pan out in tolerability. There was a reasonable amount of diarrhea, and then there was also MET-driven toxicity, particularly with peripheral edema, but again, generally speaking, low grade. Quite a lot of people develop infusion-related reactions to this antibody, but the majority of those happen with the first or second infusions, and most patients are able to continue thereafter. So this is an interesting, clearly an interesting molecule. It seems to be pretty well tolerated. It has a response rate of 40%. We saw on the waterfall plot that it's vast majority of people get some degree of tumor shrinkage, and the median duration of response is nearly a year. So it's a durable benefit seen as well. And as is the current trend, and this is, you know, quite exciting, I think, for us here in the UK. So this is on the back of this phase 1 study. Last month, this was approved by the FDA as an accelerated approval, which historically, if you go back to the days of ALK, I have a very, I'm not going to bore you with it today, but I have a very lamenting tale about the varicing licensing of ALK and how we fared worse than most in the UK. But actually, with this new Orbis program, which is an international regulatory program which the UK signed into, we are expecting, it hasn't quite happened yet, but we're expecting to see much quicker MHRA approvals in parallel with other countries, including the FDA. So we're going to see how that goes, but we're hoping to see some sort of MHRA and then subsequent access either through a no-cost scheme or hopefully through CDF and NICE in the not too distant future. So there's a really good example of a early phase study leading to license, and it makes it quite difficult when you're thinking about different trials, certainly when you're trying to talk about presentations and someone thinking, I hope you haven't heard all about this already from Sanjay. The molecule's interesting. They're combining it now with, in the first line setting, in EGFR-driven disease, with the third generation TKI, EGFR TKI, lazertinib, which is being randomized against osimertinib, so a pretty punchy study. That's just open to recruitment in the UK, as well as looking at it in combination with chemotherapy in a number of different settings. So it's gone straight from its phase 1 study to license as a monotherapy and straight into registration phase 3 studies from here in a number of different settings. So we've thought about EGFR, both the sensitizing mutations and the life beyond osimertinib and those resistance mutations. I've been using this same slide, which is quite out of date. I quite like it because it does list a whole lot of the different drugs under some of those different recognized potential driver aberrations. Of course, quite a lot of those drugs are a little bit out of date now, and I've been using this slide for about the last 5 years, and all along I've been highlighting the fact that the big unmet need is that red chunk of nearly a quarter of our patients with KRAS mutations. And of course, this is something which is now changing, because KRAS was often discussed as being the undruggable protein, how that this was not going to be able to be targeted, and it's been sort of efforts to target downstream, certainly in lung cancer, like MEK targeted therapies like selumetinib, have all proved to be not particularly helpful. So it's been very exciting over the last few years to be hearing coming through from the lab into the safety studies, into the phase 1 evaluation. In the first instance, the Amgen 510 sotorasib, as it's now named, KRAS inhibitor. So this isn't a specific inhibitor for the G12C mutation, which is about half of the KRAS mutations in lung cancer, about 13%. And the very early data preclinical data at least shows that it's quite very sensitive, very selective, and very potent, and it's an irreversible binder. And we can see in the phase 1 dose finding study, again, a very nice looking waterfall plot in the small number of patients in the phase 1 part of it, with a good response rate of more than 50%. And a durable response in the early data. This led to the recommended phase 2 dose being established. And again, in the phase 1 components of the study, the drug's very well tolerated. DLTs were not described in the dose finding component of the study. And the fact there was really almost very few grade 3 toxicities, and most of the low grade toxicities were very well tolerated. So it seems to be very well tolerated as well as effective in lung cancer with KRAS G12C. So no dose-limiting toxicities, very few SAEs, and generally very well established and tolerated at its recommended dose. Interestingly, in a similar way, this has gone from phase 1. The phase 1's continuing at the moment. It's now going into combinations with sotorasib. The phase 2 monotherapy study kind of morphed into a phase 3 study. The phase 3 study, they changed the primary endpoint so that they could complete recruitment quickly because there are other drugs coming through. So the phase 3 study completed recruitment earlier this year, awaiting the results. But actually, even before those results have come through, again, last month, we got FDA accelerated approval for sotorasib in the US. We've already got a no-cost scheme here in the UK, and we're expecting again through Orbis some sort of MHRA readout in the not too distant future. So Amgen have done so a little bit of dirty politics because they've got the first drug, they've got the early phase data, they've got their approval, and they've changed their phase 3 study, even the primary endpoint, in order to get that study completed quickly, because other companies are now trying to get their KRAS molecules. There's at least 3 or 4 of them in development, all of them in the clinic now, several of them in phase 1. At least the Boehringer and the Roche one are going straight to combinations. The Mirati one is trying to do their phase 3 pivotal single agent study, but I think they're going to struggle to recruit because there is now access to sotorasib already available in many countries. So a drug which has gone straight from early phase to accelerated approval, which seems to be a recurring theme, is certainly good for our patients if we can get access to them. So these are, again, EGFR, KRAS. I'm not going to touch upon ALK. There's quite a lot of activity across multiple different of these targeted therapy areas with new drug development. One of them I think it's worth just thinking about is ROS1. So this, again, in the UK, is one of the targeted therapies that is on the directory. So it's being tested for routinely. It's not a common translocation, but it's seen, and we now have access to crizotinib and entrectinib for patients with ROS1 disease. Again, this is old data, so I'm not sharing it with you now, but crizotinib got license approval on the back of the phase 1, again, first in human study, which again had multiple expansion cohorts, one of which was with, it was in ALK-driven disease, one of which was in MET, exon 14, as it turned out later on, and one of them was in ROS1, and it was a very small number of patients that led to approval and indeed nice reimbursement for crizotinib in that setting. But again, that reverse translation, we've now seen that one of the most common resistance mutations, treatment-driven, is the G2032R mutation, and repotrectinib is the new generation drug that's been developed, or one of the new generation drugs which has been developed, which is similarly potent, or at least as potent, I should say, to wild-type ROS1, but nearly an order of magnitude more potent than all of the other inhibitors in the 2032R mutation population. So it was been delivered to try to optimize that activity against this recognized mutation. And this again these are the data from the phase 1 study. We can see here, this is a dose finding study again, so pretty early in development, excuse me. And again, clever biologically driven trial design. So it's challenging, but even the phase 1 dose finding part of the study, this population is ROS1 or NTRK or ALK positive tumors. So you're selecting the correct patients most likely to get benefit right at the beginning, even in your first in human study, in order to get safety data, but actually to be able to offer clinical benefit because you have confidence in your drug. So, real changes in the phase 1 unit, it means that the number of studies that we have, which are genuine all-comer studies, are much less common, and actually starts getting quite tricky because we're not necessarily testing all the patients we need to for all the different biomarkers that would be relevant for the different patient populations, and that's a real challenge that we're having to fight with all the time. If we start looking at the activity of repo then in ROS1 disease, we can start seeing, of course, small numbers of patients, but pretty impressive looking waterfall plots. So again, here we have patients from different cohorts, so different doses, but pretty impressive tumor shrinkages. These are in patients who are TKI naive, some of which had brain metastases, and again, you can see good activity there. The drug was designed to have good brain penetration, but we're certainly seeing that. And you can see again, if at the recommended dose, response rates of 80%, 80-odd%. So really good response rates with good durable response seen and in and out of the brain. If you look at patients who've had crizotinib before, particularly you have response rates even in the second line setting of more than 50%. And again, you can see obviously not quite as a unanimous response rate as was seen before within the naive patients, but still most patients getting some degree of tumor shrinkage, which is including intracranial shrinkage, which perhaps isn't a surprise because we know that in both ALK and ROS-driven disease, the brain unfortunately is one of the sanctuary sites that tends to be an early relapse site for on crizotinib, which doesn't have quite as good a brain penetration as some of the other TKIs. And if we look at patients who've had 2 lines of treatment, you can see even in this setting, so most of these patients, the second line will have been LORLA. So lorlatinib is a new generation ALK ROS1 inhibitor that's definitely more potent and has a broader range of activity in ALK resistance mutations. But the jury's still out as to exactly what role it'll have to play in ROS1-driven disease, and I think probably repotrectinib, albeit the fact we've only got very small numbers here and very early data, I think it's certainly looking pretty impressive. And here's an example. I think it's a patient in the US, so it's we didn't run this study ourselves here at UCH. It was run at Sarah Cannon, just along the road. But you can see here, I think this was one of the American patients who had first-line chemotherapy, combination chemotherapy, and then discovered it has a ROS1 fusion, had crizotinib. We know that with ROS1, if anything, is even more sensitive to targeted therapies than ALK, and this patient had 5 years on criz before developing progression confirmed as being driven by a secondary resistance mutation at the G2032R site, and received LORLA for a few months only, with some minor stabilization before progressing, and subsequently received repo on study, and has had a good partial response, which was still on treatment when this was reported. So really promising data for this new agent in ROS1-driven disease. From a point of view of tolerability, unlike lorlatinib, which is actually more potent than most, but actually also reasonably more toxic than certainly alectinib or brigatinib that we use in ALK-driven disease, and you probably heard a little bit about that already earlier today from Sanjay and James. But actually, repo is pretty well tolerated. So again, you can see here when you look at all grade AEs, most patients getting some degree of toxicity, but again, the vast majority of those being low-grade toxicity, and most patients not requiring changes of their treatment schedule or dose modifications at least. Interestingly, dizziness seems to be a recurring toxicity, the mechanism which is not entirely clear to me, although we do know we see this visual problem with crizotinib, but this is actually different clinically, as I understand it, although I've not used the drug myself. So new drugs, when we're looking at ROS1 resistant disease, there's again lots of activity now looking in HER2, particularly with ADCs. We've got drugs now targeting RET, NTRK, as well as MET amplification and exon 14 skipping mutation. So really lots of exciting drugs in development, and again, many of them skipping from early phase studies to licensed approval. And this another one example of this. So pralsetinib, Blue 667, a study which we've been involved in here at UCH, is a highly potent and very selective RET inhibitor. preclinically very active in RET fusion disease across different tumor types. And in lung cancer, we can see here the phase 1/2 data expanding in non-small cell lung cancer. This particular cohort is now closed, but see really impressive activity with response rates of around about 60%, either first line or second line. So, you know, really good activity, vast majority of patients getting some degree of tumor shrinkage. And as the data mature, we're seeing that durability extend, which is very reassuring. In parallel, LOXO 292, so this is selpercatinib, which is in parallel also been developed originally by LOXO, now being developed by Lilly, and this is another very potent selective RET inhibitor. Preclinically, again, showed very similar activity in similar models, and in the clinic, we can see again response rates of sort of nearly 70%, vast majority of patients getting some degree of shrinkage, good tolerability, and good durable benefit. So we have some really exciting drugs which have come through now, available through no cost schemes here in the UK, expecting to get very soon some clarification about license. They've had, again, FDA approval earlier this year, so coming through this accelerated process. So it's really exciting that for me, that even in the 10 years that I've been at UCH, we've seen a transformation really in how these drugs which are being developed, being tested in the clinic in early phase studies. And the real change, I think, has been the recognition that these are becoming rare cancers, if they're a small proportion even of a common cancer like lung cancer, and the regulatory bodies recognizing that and allowing accelerated approval, and that's now beginning to move beyond just America into Europe as well, and here to the UK hopefully. So that's to be honest, when it comes to early phase, that's the main information I think which is good to share with you. Obviously, the other area where there's a huge amount of activity, I haven't got a huge amount of information to share with you because it's a bit of a mess really. But there's of course a huge race to try and improve upon the activity that we've seen with PD-1 and PD-L1 in non-small cell lung cancer, and I think slightly counterintuitively, the chemotherapy combination is the one that's come through first. And again, I'm sure you've heard about that earlier this afternoon. But in parallel, there's been a lot of work looking at in combinations with radiotherapy, with other novel immunotherapy or immune modulating drugs, and then other more novel treatments, whether that's vaccines, viruses, cell therapies, etc. So a huge amount of activity in this space. Most of it happening in the early phase space, to be honest. There's lots of studies and we've done lots of them, but not necessarily that exciting and not really something I think that is good to get your teeth into, to be honest. So I think I look at this conceptually, and the main activity is looking either at patients who've got resistant disease to PD-1, PD-L1 inhibition, whether that's a monotherapy or following chemotherapy, chemo-IO. And lots of combinations start there. That's the easy place to go to because there's lots of patients in that space, but it's the difficult place to be when it comes to showing activity. And actually most of the studies have been pretty disappointing so far, with very few studies showing meaningful responses in that population, particularly in the primary resistant population, but even those patients in secondary resistance. So there's lots of activity there. We've had some studies with some promise, but actually none of them, I don't think, anywhere close to being something that you need to be focusing on. And the other area is just a maelstrom of competition, looking at what can you add to patients who are checkpoint naive to try and potentiate the likely benefit of their PD-1, PD-L1. And whether that's in combination with chemotherapy or this is a monotherapy, there's hundreds of trials out there at the moment in this area, and most of them are rushing through from safety studies into randomized phase 3 studies with little time spent, I don't think, on the biology or really understanding or even the predictive biomarkers, and therefore not a lot for us to get our teeth into from an early phase perspective. There's lots of studies, there's footfall, but it's not necessarily a lot of biology. Here's just one example just to share, which is fairly typical, I think, of the sorts of studies that we're seeing coming through. This is one of the Roche studies with their TIGIT inhibitor. TIGIT's quite an attractive target. It's involved in quite a lot of different components of the tumor microenvironment and cancer immunity. And they've developed, a number of companies have developed inhibitors to it. And they've gone in combination with PD-L1 with their atezo, and the Cityscape is their phase 2 study, which is a randomized study of, it's actually a placebo-controlled randomized study, atezo plus or minus what they call tiragolumab, which is their anti-TIGIT antibody. And it's a fairly standard study, so it's a first-line study. They've selected, the studies that we see are either all-comers. We've got an all-comer study at the moment, which I think is quite sporting when you're thinking about the option of chemo IO as being there as a standard of care when you're perhaps only giving them IO plus. But we have, but certainly some of the studies are all-comers. Some of them are selecting PD-L1 1% or above, and some of them are selecting PD-L1 high only. Most of them are excluding obvious oncogenic driven disease, and in this particular study randomizing to atezo with placebo or atezo plus tiragolumab. No crossover allowed, and it's just a straightforward first line study. And you can see here the overall population response rates with what appears to be quite impressive near doubling of response, with a statistically significant improvement in progression-free survival, at least, albeit the fact that it's less than 2 months numerically, or nearly 2 months numerically. Actually, when you look at it in the subgroups, you can see in the PD-L1 high population, where we know you see activity or better activity and associated licensed activity of the single agent checkpoint, PD-1, PD-L1, you can see here a more impressive increase in response rate from 24% to 66%, whereas really very little difference in the PD-L1 low cohort. And that's seen again in their PFS curves, where you can see here no real change in the PD-L1 low, whereas a more impressive increase in their PD-L1 high population. And this has led to their phase 3 study on the back of this going purely into the PD-L1 high population. And that's again coming around the UK and other centres at the moment. So I think that's just an example. I don't think it's a particular necessarily a molecule or a study that I would put my mortgage on being the next winner, but it's an example of where these novel immunotherapies are going in combination predominantly with checkpoint inhibition. As you might expect, you see more toxicity with the combination. When you look at the overall toxicity profile, it's not dramatically different. You can see here, if you focus on the interruption, it's increased from about 30% to about 40%. You don't really see the granularity of that when you're looking at the all grade or high grade toxicities particularly, but it does appear to lead to more interruptions. And you can see that's particularly the case when you look at all-cause toxicity. You can see that there is more but predominantly early grade toxicity with the combination. Again, not a surprise, but it's very tolerable and manageable for most people as described, including higher levels of immune-related toxicity as well, but again, predominantly low grade. So finally, I just wanted to touch upon the beginnings of what I think is going to be an emerging area of interest in lung cancer, well, in solid malignancies in general, which is at least to begin with going to probably remain in the scope of the early phase teams, and we're certainly getting a bit more involved in these sorts of therapies now. CAR-Ts, I think I haven't got anything to talk specifically about now. This is very preliminary in solid cancers at all, and limited activity so far in lung cancer, or activity, not meaning anti-cancer activity, but just trials activity even. There's a few TCR studies now in lung cancer, although none of them really to report. So I'm just going to very briefly finish on touching upon some of the TIL studies, because these are quite interesting. There's not much data, they're still ongoing, so there's not a lot to share, but just for you to be aware of. Last year, one of the Iovance phase 1 TIL studies in lung cancer reported on their first 20 patients. These were patients who were treatment naive, and they had nivolumab whilst waiting for their TIL product to be developed. And in that population, they showed a response rate of about 25%, which was quite promising, but it's a bit mixed. It was, although on the tin, they described this as being an immune resistant population, actually, when you looked at it, half of the responders had actually not had a checkpoint before. And so as part of their work up to their TILs, they were getting immunotherapy. So it's difficult to know quite what that represents, but certainly some promise. And some of the responders were in patients who already had resistance to checkpoint inhibition. So this is not a insignificant treatment. These patients require, in order to make the product, they do require a surgical biopsy that then goes off to be manufactured into a TIL product. And in parallel, in this study, they got some nivolumab, but that's variable study to study. And then they require lymphodepletion, their TIL infusion, and then most of them studies have a degree of IL-2 as part of the engraftment. So they involve inpatient stay. It's a bit more intensive, and certainly we're beginning to build up our resources to be able to deliver these treatments in the hospital, and mostly having to train up our nurses again, because quite a lot of intensive chemotherapy has shifted away, certainly from us here at UCH in the oncology team. This is the next study from the Iovance team. The Iovance is sort of one of the US big spin-offs in TIL therapy, Rosenberg spin-off, doing very, very beautiful and elegant studies, global studies now, but driven from the US. And this is their lung study design. So it's patients who've had previous chemotherapy and checkpoint inhibition, and then they're in different cohorts based on their PD-L1 expression. This hasn't reported yet, this is ongoing. The UK equivalent, which I think is really the next generation of TIL therapy, is the UCL CRUK spin-off Achilles, and their lung study, the Chiron study, is the phase 2 of what they've described as CNET. So these are clonally neoantigen recognizing T cells. So this is an expansion of specific subpopulations of the TILs, which are recognized clonal neoantigens. So a more complex and clever product to develop, yet to be proven as to whether that's going to be the way to go. But that's ongoing study, again, not reported as yet. So in conclusion, I think there's lots of stuff going on in early phase studies in lung cancer. You won't be surprised to know. I think it's fascinating how this precision thoracic oncology is transforming drug development, transforming registration paradigms, and really making our management so complex. And that you will all be aware of the change, which I think is so important for to make national availability of broader testing. We've been working so hard over the years, as I'm sure many of the other centres have, where you've been training, to try and get extended molecular characterization of our lung cancer patients in order to understand the biology and give opportunities for some of these earlier drugs. But hopefully this whole GLH platform will allow that across the whole country, and there'll be less postcode treatment options, particularly as these new no-cost schemes come through. We're doing an audit at the moment, trying to work out how we can do it across the country, but looking at the implementation of these no-cost schemes and how variable that is across different centres, because it really is not very equal, I don't think. Of course, in the immune world, there's equally huge numbers of studies ongoing, really interesting combinations particularly, and the ongoing evaluation of combinations with cell-based therapies, and many of the cell therapies are combining with checkpoints, but some of them, of course, are the more novel ones, are exploring on their own. And that was where I was going to stop, if that's hopefully gives you time.
That was fantastic. Thanks ever so much for a great talk. Covered so much in that time. There's no questions in the chat as yet, so I'll start with one. So how did you get into working in phase 1 and early phase trials, and what advice would you have for trainees who are interested in working in that area, particularly if they can't get time on a phase 1 unit as part of their training?
Yeah, it's crazy, isn't it? You think about how things are changing in drug development and just in the drugs that we're using, to think that the oncology is so shifted for our oncology trainees into sort of acute oncology, which of course is one element of it, and away from the sort of the translational oncology, which seems to be so critical to the interest in new drugs. I mean, I think, you know, many of the centres that do have early phase units, we've certainly tried to build into our rotation the opportunity to get at least a taste of it. You don't really get much exposure in 6 months, but you get a feel for the sort of stuff that's happening, you get a bit of a taste for it. But most of the units, whether that's with James in Guy's or the Marsden or ourselves, most of them will have fellowships. So I think there's often opportunity if people want to get to try. You can do a year out of program. What we have in our fellows, we have a mixture of people who are pre-number who come and they do a year with us, and then they kind of either go and do a PhD in the lab, or they get their training number whilst they're with us. But people in training likewise can come during their training or even at the end. And we've had several people who are post CCT who come to get a year. I think it gives a great opportunity to get some publications, to get some experience, even stuff like not even only early phase, but writing protocols, developing trials of your own. You just don't get much exposure to that. And we can offer that opportunity to try and get a bit more experience in all aspects of sort of clinical trials, really.
That's brilliant. Thank you. And then just one more question, if I may. So you started off by speaking about kind of trials and targetable mutations, but since that group is much less common, how do we kind of rationally recruit patients into the right trials, particularly with we'll be doing more mutation testing, but you may worry, as the point you made at the beginning, that people are, the wrong numbers are ending up in the wrong trials.
Yeah, so I think, so I guess quite often, although we're learning as we go along, quite a lot of the oncogenic driver changes are mutually exclusive. So I think that one of the things I think we really have to sort out is the systematic testing of our patients, so we can really understand what's driving their malignancy, and try to. And I think one of the big changes we're going to see, which as I say, frustrates me that people cleverer than me are not doing it yet, is how we're going to start to personalize our immunotherapies, because I think it seems to me that there's so many different checkpoints out there, so many different drugs, and there's so much better understanding about the immune biology and immune regulation that surely the next step is going to be trying to personalize which drugs are right for which person, rather than just giving everyone. And as I joined, I heard Tom talking about adjuvant, Atezo. Well, surely we should be able to work out who needs Atezo and who needs something different, because the biology is there. But so I think there's a lot more for us to learn when it comes to those different patients. But when it comes to the sort of molecular drivers, actually, most of those are quite early clonal events, and so most of those will be there's not many of them within the tumours. And we've just looked at MET, for example, and sometimes that's not always the case. Sometimes you do get more than one dual mutation. That's pretty uncommon and so often caused by treatment pressure as we go along with different therapies.
That's brilliant. Thanks ever so much. So I'll hand over to Dan to close the session.
Thank you.
That's great. Thanks very much, Martin. It was a really great talk and inspired me, if not anyone else, to come and do some phase 1 at some point. So thanks very much. So thanks everyone for joining. We've had over 50 people at any one point join, which is excellent. So really appreciate you calling in, and we also appreciate that this is not an interactive a meeting as we normally would have, with lack of catering, but we hope that we'll get back to our face-to-face meetings sometime soon. At least the ACP is planning on hosting its trainees weekend face-to-face this year. and that will be the weekend of the 17th of October, so put that on your diaries now, and that we're aiming to do that in Bristol. So hopefully, if I don't see some of your faces before, we'll see you then. Thanks very much, and we will try our best to make this recording available afterwards if the speakers are happy, and please do complete the survey feedback in order to get your certificate afterwards. Thanks very much and enjoy the rest of your evening.